Good morning, distinguished guests, colleagues, and friends, and welcome to the global event, Shaping AI in Health. Over the past 2 days, we have had a productive and inspiring technical workshop, sharing experiences, exchanging ideas, and learning from one another. Today, we are pleased to build on that momentum as we begin this global event. Before I start, I'd like to share a few practical announcements. After the opening session, we will take the official group photo. The group photo will be downstairs outside this building. We have also 2 cartoonists who will be with us all the events. May I now kindly invite your speakers to take their seats on the stage. It's a great pleasure to invite Dr. Hans Klug, WHO Regional Director for Europe, to deliver this opening address. Dr. Hans. Thank you. I also will call Dr. Alan Lambrick, Director of Data, Digital Health, Analytics, and AI from WHO headquarters. Dr. Alan. And Professora Doutora Ana Paula Martins, Minister of Health from Portugal. And now, Dr. Cole, can you please say a few words and welcome to Portugal.
Thank you. Honorable Dr. Ana Paula Martins, Minister of Health of Portugal, my great friend, honorable ministers, deputy minister, distinguished colleagues. Bom dia. Sejam bem-vindos a Lisboa. Welcome to Lisbon. My very sincere thanks to the honorable Minister of Health of Portugal for bringing us together at such a crucial moment, and allow me to acknowledge the outstanding leadership of the Government of Portugal in advancing digital health and artificial intelligence, both nationally, regionally, and globally. Also, a special thanks to my respected colleague and friend, Dr. Alain Labrique from WHO headquarters, who is always with us. Actually, we consider him also European region, but as a one WHO family. Thank you, Alain. Thank you. I particularly would like to warmly welcome the ministers from the Lusophone countries, alongside all the ministers and distinguished participants joining us from across the world, including also our respected colleagues and friends from the European Commission. Thank you very much for always joining, and greetings to Ms. Sandra Galina, the DJ. We meet in Lisbon. 500 years ago, this city was the point from which European sailors set out to explore the world. Today, we stand once again as the horizon stretches before us, a horizon this time of technological advances, innovation, and human possibility. But unlike in the past, we already know one thing with certainty. The future of artificial intelligence is not distant. It is upon us. It is changing how health professionals work, how patients receive care, and how we detect diseases. Now, the good news is that nearly all countries in the pan-European region report adopting AI for one main reason: to improve patient care. So the question is not whether AI will transform health, but whether we will shape that transformation or simply react to it. Across the WHO pan-European region and beyond, we already see inspiring examples. In our host country, Portugal, the Coimbra local health unit, where the minister and me were yesterday, is using AI-powered image analysis to support radiology in primary care and emergency rooms, improving diagnostics and cutting waiting times while keeping all clinical decisions in the hands of trained health professionals. In the United Kingdom, the National Health Services AI Laboratories National COVID-19 Chest Imaging Database has brought together over 81,000 scans, accelerating the development of diagnostic AI tools while setting important standards for how such systems are tested and evaluated. In Turkey, AI is integrated into national breast cancer screening for women aged 40 to 69, supporting detection, reducing radiologist workload, and accelerating diagnosis, while relying on anonymized data managed under national data protection requirements. And during my visit to China last year, I saw firsthand how AI and digital tools are improving care in rural hospitals. A powerful reminder that when implemented responsibly, technology is a force for health equity. These examples show AI helping clinicians diagnose earlier, reducing administrative burden, expanding access to specialist care, and improving equity. Yet, they also remind us of something fundamental. Technology alone does not transform health systems. It is the trust that does. And this imperative extends well beyond the health sector. Only days ago, leading cybersecurity agencies from 5 countries jointly warned that AI is transforming cyber risks in months, not years, calling on leaders to treat cyber resilience as a strategic responsibility rather than simply a technical issue. Their message echoes ours. Innovation should go hand in hand with governance, preparedness, and trust. In health, people do not adopt technology because it is intelligence. They adopt it because they trust it. And that trust is built only when it is clear that AI serves the people's interest. And this principle must be at the very core of how we shape this transformation. Dear colleagues, dear friends, let me set out 3 elements to achieve this. Number 1, how do we build the conditions needed to earn that trust? Our latest regional assessment shows encouraging progress, but also huge gaps. Only 8%, imagine 8% of countries in the region have a dedicated health-specific AI strategy. Only 1 in 5 provides AI training before health professionals enter practice. And only 1/4 offer the training once they are in the workforce. Almost 40% still lack operational guidance on the ethical use of AI. Madam Minister, this meeting could not be more timely. These numbers represent doctors, nurses, and patients being asked to embrace AI, but without the policies, without the guidance and support they need. Health workers will not use AI with confidence if responsibilities are not clear. Patients will never trust AI if they do not know how decisions are made or how their data are used. And societies will not benefit if this transformation widens the very inequalities we're trying to reduce. This also requires us to look closely at who is shaping AI. Our colleagues at UN Women rightly remind us that AI has enormous potential to challenge harmful masculine stereotypes, broaden representation, and improve access to services. But those opportunities will only be realized if women and girls are fully involved in designing, developing, and governing these technologies. And we must also recognize the risks that are already emerging. Misogyny, discrimination, and technology-facilitated violence against women are increasingly reflected and amplified in digital spaces. That's why I have called violence against women and girls in my region a public health emergency. 1 in 3 women in our region experiences physical and/or sexual violence during her lifetime. AI must never reinforce the prejudice and power imbalances that drive this violence. For WHO, this is not only a technological challenge, it's a matter of health, human rights, and equity. We must also avoid what some have described as data colonialism, where data generated in one country create value in another country without bringing benefits to the people who created them. Today, fewer than 1/3 of countries in our region have established frameworks for secondary use of health data or cross-border data exchange. My dear friends, AI shall reduce inequalities and not deepen them. But this requires cooperation, shared standards, and collective leadership across countries, which is precisely why this conference is so timely. And I'm very, very grateful to all ministers, former ministers. We have former president of the World Health Assembly even among us. It's amazing. So, number 2 now. How do we move from principles to action? Across Europe, governments are asking remarkably similar questions. How do we regulate AI without slowing innovation? How do you protect people's rights while unlocking the potential of data? How do we prepare our workforce? And how do we ensure that every country, not only the most digitally advanced, can benefit? These questions have guided the WHO European Roadmap for Action on Artificial Intelligence in Health 2026-2033, which member states will consider this October at our regional committee. And it's not just another strategy, it's a very practical roadmap for implementation, shaped through one of our most extensive consultations. It complements work already underway within the European Union and Commission, and thanks again, dear Marcelo, for the very close collaboration, but also the OECD, and it recognizes that countries have different capacities and resources, but no one should be left behind. And finally, number 3, how do we ensure ethical AI in health is a shared global responsibility. This conversation is about much more than Europe. The principles of equity and solidarity extend far beyond our region. And that's why we have convened this meeting here in Lisbon. People's health needs and the innovation we are all witnessing have no passports. They know no borders. Allow me to close with the words of Portugal's famous Nobel laureate, José Saramago. Quote, "If you do not step outside yourself, you will never discover who you are." Unquote. 500 years ago, Lisbon was the starting point of journeys with an Eurocentric perspective. Today, it can help us shape an age of truly global, responsible artificial intelligence. Learning from one another, building trust across borders, and we must ensure that it's us, public health experts and policymakers, who shape the AI transformation as a shared public good, never as a source of greater inequality. The question is not whether AI will shape our future. It's whether we will shape AI in a way that earns people's trust, strengthens health systems, and leaves no one behind. That responsibility belongs to all of us. Obrigado.
Thank you. Thank you, Dr. Kugel, for your inspiring remarks. I do now invite Dr. Alan Lombrick to say a few words.
Now, Dr. Klug always sets a very high bar to follow in his footsteps, but what a rousing speech and what a way to start the morning. Dear Minister Ana Paula Martins, ministers, excellencies, fellow dignitaries, of course, Dr. Klug and distinguished delegates, and of course, colleagues who have come here from WHO offices around the world. Bom dia and muito obrigado. I won't even try to match my colleagues' wonderful Portuguese pronunciation. But welcome to Lisbon. I bring you the warm greetings of WHO DG Dr. Tedros, who's following this meeting very, very closely. But I also want to thank Portugal and the many partners who have made this convergence of people possible. The hospitality of Portugal and the Lusophone world is well on display, and the two-day workshop that we've just emerged from, starting on Monday of this week, really is a recognition of that considerable hospitality. I also want to recognize Portugal's recent leadership of the Global Digital Health Partnership, which is one of WHO's very proud accomplishments for many years ago, where we established a platform together with member states for government-to-government sharing of experiences in digital transformation and now artificial intelligence. And I think that peer-to-peer learning is why we are here together in Lisbon. But I want to begin with something that happened while many of us were in trains, planes, and automobiles coming to Lisbon for this conference. Yesterday morning, Dr. Demis Hassabis published a framework for governing frontier AI. For those of you who may not know this name, and I doubt there's anyone in this room who does not, he is the head of Google DeepMind, but also the Nobel Prize winner for his work on frontier models and the foundations of AI. And by many measures, he is one of the people who is best placed to understand what these systems are capable of. He proposes in this open letter that he published yesterday, a standards body funded by industry, answerable to one government, which would test the most advanced models before they are released for their dangerous capabilities in cybersecurity, in biology, in deception. He also writes that today's risks are warning shots, that within 18 months, capabilities we would consider as a health audience extremely serious could sit within open models with no government controls. But I would ask you to notice two things about this document. The first is that it's a remarkable act of candor, and we should recognize this. When the people who are building these systems tell you that science cannot guarantee safety, as the new UN's scientific panel with two other leading experts, Joshua Bengio and Dr. Reza, also told us last week in Geneva, the correct response from all of us is not skepticism, it is attention. The second thing to take away from that letter is that there is no Ministry of Health represented in this governing body. The board is proposed to be made up of technical experts, industry, government, open source experts, but it's a national body in one country for one market that has implications for the entire world. And the model that it's built upon is one of financial regulation, not health. And it's not a criticism of Dr. Hassabis, it's a description of where we are standing today when we talk about artificial intelligence. The governance of the most consequential technology of our lifetime is being designed at speed in rooms where health is not represented, by institutions who are never built to think about a patient, or equity, or gender-based violence, or even digital colonialism or exploitation. The excellent comments that Dr. Kluge raised about the opportunity and the risk of this technology. But that brings me to why we are here. Last week, the United Nations Secretary General convened the first member state resolution mandated global dialogue on artificial intelligence governance. This was co-chaired by El Salvador and Estonia. Every member state at one table for the express purpose of governing this technology. The Secretary General named 4 priorities: common safety standards, human rights red lines, capacity for low and middle income countries, and most importantly, something we don't speak enough about, environmental transparency. What is the true cost of AI, especially when we use technologies not because we need to, but because they are there? Health has a claim on the table that no other sector can make, because health is where the consequences of a bad system are not just measured in dollars lost. We measure consequences in morbidity and mortality, the loss of human life. And that's why I think we have a special duty of care to be part of this conversation of governance of artificial intelligence. Both co-chairs, Estonia and El Salvador, left this dialogue last week with one ask: go home with commitments, not just communiques. And I think that's a really important lesson for us. And Lisbon is where that hard work begins, because this is the first meeting after last week's high-level political dialogue where we will be rolling up our sleeves and talking about the things that we need to do to act on those aspirations. So let me put the global picture to you plainly. Across all 6 regions, ministries have embraced what these systems can do: diagnostics, surveillance, triage, some relief for a workforce that is far too limited and in many cases exhausted. The enthusiasm is valid, and as Hans has said, many countries are still working on the foundations necessary to adopt AI responsibly. For those of you who are researchers in the room, you also have made a very strong claim that the evidence is younger than the enthusiasm. Most published health AI reports still are on internal validations rather than on prospective randomized controlled trials or rigorous research. When a model crosses a border, as you elegantly said, health has no passports. And those models meets a population on which the data was not available and that model was not trained on that target population. We have documented performance drifts. But here's the thing: performance drifts are quiet. They don't announce themselves like a bad drug does. When generative systems arrive in clinics, they carry a failure mode that medicine has never had to govern. A wrong answer, delivered fluently, confidently. All of us have used one of these models where it tells us something that's factually incorrect, but with a degree of confidence that makes us question even our own understanding of a subject that we may be experts in. But this is the sentence I would ask you to carry out of this room. We have spent a century building the institutions that catch drug and medical device problems: pharmacovigilance, adverse events reporting, market withdrawal, liability. But we have barely begun to create the systems that catch errors in AI-enabled systems. But the models are not waiting for us to develop those safeguards that protect people from dysfunction. So I will also like to leave you with 3 things for the 2 days that we have together ahead. 1, without any doubt, government belongs in the driver's seat. Not the vendor, not the platform, not the funder. A ministry that cannot inspect a model, cannot audit its performance in its own population, and cannot withdraw it from service does not own that system. It rents it, it inherits it. And the owner of these systems may not be accountable to your government. And that is not sovereignty. So we have to talk about this. The second, as my respected colleague from WHO Euro has said, is context is everything. The question is never whether a model is impressive. We've heard some excellent examples from Turkey to China to right here in Portugal. The real question is whether we are using AI to solve a problem that we actually have for the people that are furthest behind in the system that we're actually running. And when the answer to that question is no, we have to be willing to say so, plainly, despite the possible sunk costs in testing and developing that innovation. Over the last 20 years, health systems have absorbed a great deal of expenditure in innovations that were never meant to be mainstreamed or absorbed into health systems. And we are at a point in global health where health systems can ill afford to continue to do experimentation without a plan for integration and scale up. Third, no country should be forced to choose between sovereignty of its data and the safety of its people. Dr. Klug has spoken to this, and I will only add that sovereignty is not isolation. The fact that we are gathered here in this room from every corner of the planet is evidence of that statement. Sovereignty is responsibility, knowing where your data sits, who processes it, whose laws govern that data, and on whose terms that model can be taken away from you. I don't need to give specifics, but we've all seen in the last few weeks how the sudden withdrawal of a model left many entrepreneurs and developers feeling short that they had invested a lot of energy in a system that they were not in control of. To the donors and industry colleagues in the room, I have one sentence. What is scarce right now is not capital and it is not compute. It is the evaluation, regulation, and digital public infrastructure that a health minister can actually trust. And that is the unglamorous half of this field. It is the half that determines whether any of these innovations can actually scale. And most importantly, whether these innovations can reach a patient. Yesterday, the results of more than 1 year of work by experts convened by WHO, architects from every region of WHO came together to develop a digital health and AI blueprint known as the reference architecture. This was released for public comment, and we hope that all of you will go and look at this document as part of that essential roadmap to building the foundations necessary for success in digital transformation and artificial intelligence. I close with the statement that we in health have a duty of care. We have a duty to the public to differentiate what is a high-quality system from a shiny object before we advise a minister on what decisions are best for the interest of their people. That is the work we have cut out for us in the next 2 days. Let us learn from each other, let us be inspired, but let us also ask the difficult questions. Because if we don't ask those questions, nobody else will be asking them. We can strengthen the road ahead together. On behalf of the World Health Organization, muito obrigado, and welcome to Lisbon.
Thank you, Dr. Ellen. It's always a pleasure to listen to you and learn a little bit about AI. And now it's my honor to call Her Excellency, Dr. Professora Ana Paula Martins, to say her opening remarks.
Good morning. Excellencies, Regional Director of the World Health Organization for Europe, ministers, distinguished representatives of the 6 regions of the World Health Organization, dear colleagues, partners, and friends. It is with great pleasure that I welcome you to Lisbon for the event Advancing Artificial Intelligence for Health. The presence of representatives for all 6 regions of the World Health Organization, including numerous ministers and government officials, demonstrates that artificial intelligence and the digital transformation of health systems have become strategic priorities for public health. I would also like to extend a warm welcome to the representatives of the Portuguese-speaking countries and to express my particular appreciation to the Minister of Health of Timor-Leste for her presence and leadership, which will help strengthen collaboration among our countries and within the Community of Portuguese Language Countries, CPLP, in this strategic field. Excellencies, artificial intelligence is not an end in itself, but a powerful tool to help health systems respond to some of the major challenges of our time: aging populations, the growing burden of chronic diseases, workforce shortages, financial pressures, and rising public expectations regarding access to and quality of care. To realize this potential, we need high-quality data, interoperable systems, and governance models that ensure trust, security, and the responsible use of technology. When used ethically and grounded in evidence, artificial intelligence can contribute to more efficient, sustainable, and people-centered health systems, reducing administrative burdens and freeing up professionals' time for what no technology will ever replace: the human relationship, empathy, and care. It also can support clinical decision-making, improve resource and service management, strengthen epidemiological surveillance, and bring healthcare closer to remote or vulnerable populations, thereby helping to reduce inequalities and improve the quality and safety of care. At the same time, artificial intelligence raises important challenges related to governance, data protection, algorithmic transparency, equity, public trust, and accountability in decision-making. And no country will be able to address these issues alone. We need international cooperation, the sharing of experiences, and the building of trust among governments, regulators, researchers, health professionals, industry, and civil society. This is precisely the purpose of this meeting. Over the next 2 days, we will have the opportunity to learn from experiences in different settings, discuss common challenges, identify opportunities for collaboration, and strengthen relationships that will endure well beyond this event. Because innovation in health is driven by technology, but above all, people and the connections between them. Portugal is particularly honored to host this global dialogue. Over the past decades, our country has invested heavily in the digital transformation of healthcare and has developed significant expertise at the intersection of artificial intelligence, data science, health innovation, and public policy. Portugal already has concrete examples of the use of artificial intelligence in areas such as triage, clinical decision support, resource planning, and population health monitoring, while actively participating in European and international initiatives in this field. We are convinced that the future of artificial intelligence in health will depend less on the technology itself and more on our collective capacity to implement it in an ethical, safe, and needs-based manner. And Portugal wishes to continue contributing to this common effort by making its technical and scientific expertise as well as its experience in international health cooperation available to the international community. I would like also to acknowledge the support of the institutions that made this meeting possible. The Ministry for State Reform and Public Administration, the Ministry of Foreign Affairs, the Ministry of Economy, the Lisbon City Council, Aga Khan University, and naturally, the World Health Organization. Dear colleagues, dear friends, the history of public health teaches us that technology alone never solves problems. It is political choices, strong institutions, international cooperation, and the ability to place people at the center of decision-making that determine the true impact of innovation. May these 2 days help us to move forward on that path, a path where artificial intelligence strengthens the humanity of healthcare, help reduce inequalities, and makes innovation a shared opportunity for all of us. I wish you all productive discussions and a very pleasant stay in Lisbon. Many thanks.
Thank you very much, Professora Doutora Ana Paula Martins, for your thoughtful address. As always, your words remind us not only the opportunities ahead, but also the values that we should guide as we shape the future of AI in health. So this concludes our opening session. May I now kindly invite you to join me at the group photo outside of the building downstairs. Thank you very much.
Trying to keep up with you.
So this would be Kira. Kira, Adam, you.
No, he's not going to sit. He's not sitting. No. We don't have a name. It's not. No, it's fine. We're good. She said he's not on the stage. So it's, yeah.
Can I just put a little more? It's in front of everyone else. Ah, perfect.
Inside, please.
Yes, yes. Good morning again, dear colleagues. If you could please take a seat, we are going to start in 2 minutes. Thank you so much. Obrigado.
Your Excellencies, distinguished guests, kindly take your seats as we will start with our first keynote. Let us welcome Marco Marcella to the stage. Marco Marcella is Director for Digital EU4Health and Health Systems Modernization at the European Commission's Directorate General for Health and Food Safety. In this role, Mr. Marcella oversees the implementation of the European Health Data Space Regulation, the implementation of the Health Technology Assessment Regulation, DG Santé's work on health system modernization, as well as the EU4Health program. Prior to his current position, Mr. Marcella held various roles within the European Commission, including head of unit for e-health, well-being, aging, and head of unit for learning, multilingualism, accessibility at the European Commission's Directorate General for Communications Networks, Contents and Technology. He will share the EU perspectives on health data and AI.
Many thanks, many thanks. Good morning, dear Minister, the Director General, Your Excellencies, representatives of the Government of Portugal that organized and co-hosted this event, distinguished colleagues, ladies and gentlemen. I have to say that it's an absolute privilege for me to join you here in this landmark event, the Global WHO AI Conference. And it is a very timely moment for discussing the matters here because we are at a historic juncture. It's a juncture where the technology and medicines, they are merging faster and faster. And so today I will bring to you the European Union perspectives on this revolution, a vision that builds essentially on scalable, safe, human-centered digital ecosystems where, as highlighted by my predecessors, it's based on data that flows securely, and it's securely to power the artificial intelligence in such a way that it serves public health. So this talk will not be about what AI can actually theoretically do in medicines, but actually, because you know that very much already, I would rather give you the perspectives of the European perspectives on questions that is a bit harder, and it has been hinted already to the matter. What does it actually take to get artificial intelligence systems deployed safely at scale across health systems? So let me start probably with the why this discussion, it's important, that it is important right now, and certainly it's not abstract per se. Clearly, our health systems are under strain, the demands are rising, so we have issues related to an aging populations, we do have an issue of workforce shortage. These are structural situations. A quarter of the deaths in the European Union, they stem from behavioral risk factors that are largely preventable through earlier detection. And if you look at finance, health absorbed roughly 10% of GDP in Europe in 2023. Now, all this is under that part, there is sitting a sort of 8-year gaps in life expectancy between the best and the worst performing EU countries. And when it comes to digital access, these differentiations is still deeply uneven. We do monitor the situations at European level. The State of the Health in EU 2025 report goes exactly in the same directions. And the message that we get is that we do need to invest in capacity, in equity, and AI, it is a lever for these elements. Well, probably not only a lever, it is the key magnifying factors today. So, where do we see artificial intelligence helping us? In 4 places, to be very concrete. First, as you know, we can get answers through early detections. We can certainly get to better decisions through more informed care. There could be less frictions through efficiency and through automations in part of the clinical work that we that do require a different set of competencies to deliver, and certainly on a safer and more personalized care through pathways that are tailored. Now, the ambition here, it is simple to state. So prevent, diagnose, and care at scale. The hard part is how do we move from the ambition to delivery. The hard part was indeed analyzed, and I mentioned here 2 reports the one organized by the European Commission and published in 2025, and the other one by the WHO Europe already mentions on artificial intelligence reshaping health systems, and they both get to the same conclusions, that the bottleneck, it's not necessarily the technology, and probably nor the AI model and the LLM that we are using. The bottleneck is in everything around that model. And when we looked at the matter, we identified 4 families of barriers that, that we will need to discuss also at global level. Certainly, technological and data challenges, interoperability, data standards, even fragmented infrastructures. The part related to a complexity, regulatory complexity, a part related to organizational and business challenges. There are funding gaps, there are unclear value assessment, and as we heard from Alain today, the doctor-patient relationship that has to absorb a new actor, it is also part of these challenges. And finally, the social and cultural challenges as part of this equation. Now, this takes me to an important message that I would like to pass today, that the fact that we are good in developing AI solution, so that we do have technical capacity and we do get very high scores in benchmarks, well, it does not necessarily translate into implementation. And both these reports demonstrates that. It also tells us that automating a task does not necessarily eliminate the task, and certainly does not eliminate the expertise that is underneath that task. Now, the conclusion that follows is that essentially adoption per se is not a model, it's a system. And let me elaborate into these subjects. First of all, let me stress one findings that we see in one of these reports, the one commissioned by the European Commission. It is about the perceptions on the use of AI. So here it gets quite interesting. And by the way, it is where the data gets us into useful elements for policy. We asked 3 groups of professionals. We asked healthcare professionals, we asked hospital representatives, and AI developers. Where do they see the needs? And one thing is quite interesting here, that they largely agree, on the need for optimizing resources allocations or workforce efficiency. There are majorities across these groups, but look at where they diverge. It's much more interesting here. It is on the skills gaps of the health workforce, for instance. So the developer of artificial technologies, of artificial intelligence technology, they are much more confident than the clinicians. And improving engagement and adherence, again here, there is a gap, again, from what it is built and what it is trusted at the bedside. So it's the gap, this gap, that it leads to a adoption project that in this case it is qualified. So technically speaking, if the people who build the systems and the people who use them don't agree on what we can deliver, then we don't have a development and a deployment strategy. We have a piece of negotiation that is not finished, and that we need to work on this. So closing the gap, it is, in my opinion, one of the most important and consequential piece of work that we have to address collectively these days. So how do we, at the European Union level, how do we address this problem? So what is our answer? So we are building artificial intelligence, certainly, that serves public health. And we are doing it, as I mentioned, in a scalable, safe, and human-centered way. Ethically grounded and clinically useful. Sorry, this is not a slogan. This is a design mechanisms to deploy solutions that serves public health. So we have a first level regulations that set the rules on the road. And they include the general data protection regulations for privacy, the medical device regulations for safety, the European Health Data Space for treating data, and the AI Act to get into the artificial intelligence parts of the equation. Now, to make these rules work in practice, you need collaboration. And that is the second layer, where we do work with initiatives like the Apply AI strategy, or even the European Reference Network for Rare Diseases, very specific case for a very specific set of disease. And the third one is that to support these transitions, you need funds. And for these reasons I mentioned here, Horizon Europe, EU4Health, and the Digital Europe Europe Work Program. Now, let me also be very clear that none of these three legs would work on its own. Regulations without funding is aspirations, and funding without collaborations may lead to fragmentation. So we need the three things to work together. So let me go through the first part, the legal part of the equation, very rapidly, because this is a genuine, distinctive approach to rules. And I don't think that we do have an examples of this stack on which we can make it as a reference. So the picture has three layers. The first one, at the base, we do have safety and robustness of artificial intelligence. And you have the AI Act, the medical device regulations, the clinical trial regulations, health technology assessment, and the revised pharmaceutical legislations that are underpinning that level. Safety and robustness. What do we have in the middle? We heard this morning. We have security and trust. We have the link with the cybersecurity strategy and the regulations that underpin authentications, for instance, online. And on the top of it, we have the level related to data availability and sharing with European Health Data Space regulations, the Data Governance Act, and GDPR. So what is my message here? That this is one interlocking system. These are not different pieces that are working in a disparate way. No. So they are interlocking systems for making sure that what we are discussing today happens in a way that is acceptable to all of us. And pay attention, so I put on the side a target, this e-health target under the 2030 digital decade. You see, 100% of European Union citizens should have access to their electronic health record by 2030. Achieving that requires those elements, and pay attention, this is not an aspiration, this is a deadline, we will do it. So, just a moment on the specific regulations. The AI Act, it is there to make sure that systems that are placed to the market are safe and they respect the fundamental rights and the EU values, still stimulating investments and innovation. As you see, it is a risk-based pyramid approach where you have unacceptable risks, like, for instance, social scoring, that is prohibited outright. You have the most clinical, for instance, AI parts of the equations that are permitted, but they will be subject to compliance requirements. And you have the minimal risks AI that are permitted without restrictions. Now, the AI Act does also gives us the possibility of creating regulatory sandboxes and real-world test pathways so that we can test out innovative AI. And we do so with the governance structures that is designed to make that implementations really work. The second piece of legislation certainly is the medical device regulations and the DVR, and which we are revising now. We are revising because predictability and speed matters as much as rigor, and the revisions aims to reduce administrative burden and makes the requirements proportionate by supporting innovation and promoting also international cooperation. Now, the goal here is very clear. It is to make our industry more competitive and also internal market more stronger. Biotech Act, and I show you, this is a piece of regulations that has been proposed by the European Commission at the end of 2025. It's a new act that extends exactly the same logic, but it extends it upstream into the biotech innovation. Now, on the regulatory side, we have simpler, faster, and more predictable, for instance, authorizations for clinical trials, the sandboxes. On the industrial side, we include strategic projects for boosting biomanufacturing capacity. And sitting inside all of that, we do have AI and data. AI and data, AI-enabled innovation throughout the biotech life cycle with an improved access to quality data, digital testing environments, and guidelines. Now, obviously clear to everyone, none of this work would actually deliver without solving the data problem underneath. So the fact that there is fragmented health data and lack of quality data. Silos across providers, across regions, different formats, different coding standards, incomplete data sets, biased data sets, very difficult to build a trustworthy AI systems if you don't address that problem. In the European Union, we set out a project that covers regulations and infrastructure, a systems that delivers and works on two tracks, that enables the citizens to access their data and empowering individuals to control their own data, and the second, access data for research, for innovations, for patients, for professionals. And the promise is very simple. You know, we have safer care with less duplication. As mentioned today, all of this, we do have trust as part of the foundation. Trust requires cybersecurity, and in healthcare, which is where the data is intensely personal and its stakes are literally life or death, that trust has to be earned every day. Now, at the beginning of this year, of last year, the Commission has adopted a cybersecurity in hospital action plan. And this sets a number of requirements, including for treating EU-wide incident response protocol. Let me finish with one boost, and that is the money. The next multi-annual financial framework of the European Commission, we will be dedicating, according to the proposal of the European Commission, a total of 2 trillion euro to boost, or to create a multi-annual financial framework. It will be different compared to the current multi-annual financial framework. There will be a component on national and regional partnership, and there will be a European Competitiveness Fund, which will include health and competitiveness. So let me close where I started. I believe that the technology per se is not the constraints. We need to work together also over these 2 days to turn our capability into something that the clinicians can trust, a hospital can integrate, and a patient can benefit from safely. So thank you very much for the opportunity, and let's work together to deliver on these ambitions. Thank you.
Thank you, Marco, for that great presentation and that final line. Let's work together to deliver. And indeed, this is what we are doing. Good morning to everyone again. I'm Natasha Tsopardi-Muscat, and I head the Health Systems Division with responsibility for artificial intelligence amongst other pillars at WHO's regional office in Copenhagen. And we now come to have a discussion on some of the issues that Marco was really depicting very nicely. Where are the gaps? Where does the theory then not match what is happening on the ground?
but also what is moving, what can we be proud of, our achievements. And I'm really pleased to say that we have a high-level panel from around the world joining us today. And I would like to invite to join me here and take a seat on stage Dr. Silvia Paula Valentin, Minister of Health of Angola. Dr. Asik Grigorian, Deputy Minister from Armenia. Dr. Alexandre Padilla, Minister of Health of Brazil. Dr. Kiran Gopal Vaska, Joint Secretary from the National Health Authority, Ministry of Health in India. Dr. Ali Jafarian, who is Senior Advisor to the Minister of Health in Iran. And Dr. Francisco Pinheira Catalão, Secretary of State, here with us in Portugal. So we've also been asked to try to make up for some of the time to allow you to get to your coffee break and ensure that we can get to our other interesting plenaries for the day. And allow me to kick off with a question to the Minister of Health of Angola. Before, I would like to remind everyone that we are going to try to keep interventions to 5 minutes. But I know that Angola has been pursuing some really important reforms. And if I would ask you, what is most critically important in the deployment of AI for the leadership of Angola at this point in time?
Thank you very much. I will start by compliment my fellow panelists. And I have to thank the Ministry of Health of Portugal for hosting this conference in partnership with the regional direction of WHO, distinguished participants. Allow me to say that Angola is coming a long way on this regard of using the technologies. We have a political will and strong leadership of our President, Lorenzo. We are investing a lot in infrastructures. Right now we have a satellite, the AngoSat, and also we are invest on connectivity. As I said, we have the infrastructure. We are strengthening the skills of health professionals so that the artificial intelligence can be adopted in ethical, responsible, and sustainable way. Above all, the artificial intelligence contributes to reduce the inequities in access of healthcare rather than increase them, and ensuring that benefits of technology innovation reach everyone. Angola is already using this technology in several platforms to improve health data management, the National Health Information System, with encouraging results. In this area, we have Rediff platform. Using this platform we are using for individual vaccination registration. Its interoperability with IOTA platform for digital management of vaccines and other public products. And progressive integration with National Health Information System based on DHIS2 and the analytic dashboards. Angola also has been modernizing the governance of health systems through progressive digitalization and administration and management process, including the clinical management of patients, recording significant gains in terms of efficiency, organization, and access of information. And at the same time, the country is already incorporating solutions based on artificial intelligence into delivering healthcare, particularly in diagnosis and clinical intervention. With promising results. In this context, we are working with the telemedicine. We are expanding the telemedicine. We are using robotic surgery, diagnostic and intervention imaging stands out. Angola became the second country in sub-Saharan Africa to introduce robotic surgery into the national health system. And we are performing also telesurgery all the way from Orlando to Angola using this technology. And we rely on technology support of WHO and other partners. And we believe that medium and long-term strategy that reflects the national priorities to ensure sustainability. Thank you very much.
Thank you very much, and I think that's really remarkable, hearing how this is making a difference in practice. Let me now come to Armenia, Deputy Minister Gregorian. I had the opportunity to be in Armenia earlier this year and witnessed firsthand some of the far-reaching reforms that you are carrying out also in universal health coverage. But how are you working to ensure that this ambitious reform really can, through the use of AI, bring safe and equitable health services to the population?
Thank you, Dr. Azapardi. First of all, I also would like to join my colleague in thanking WHO for convening this event, and also to Government of Portugal for such a welcome hosting us and welcoming and hosting us in such a beautiful city, very rich of history and culture. Speaking about the situation with AI in Armenia, so in today's fast evolving digital landscape, there is a real temptation to constantly experiment with IT and AI solutions. However, we need to focus on solutions that rapidly improve care for every citizen. And AI should be introduced because there is a clear, defined clinical or public health problem and measurable benefit and responsibility pathway to implementation. For Armenia to use AI for the public good, for health, highest health outcomes, we need to select a number of high-value cases where AI solutions may focus on health priorities. For example, in our newly introduced universal health insurance system, we need to use AI to support actuarial pricing and forecasting, as well as claim administration and fraud detection, which we already do using special models for claim auditing, both doctors and insurance experts. They are using this, which really helps them audit the huge number of claims which we are now receiving because of introduction of universal health insurance and doubling and tripling the number of patients which now are in the system and apply for care. Another use is facilitate earlier diagnosis of non-communicable diseases and strengthen screening programs. Also forecast public health risks. Also expand access to care to support remote populations which have, where there is a shortage of health personnel. Second, Armenia needs a stronger data quality accountability, common interoperability standards, secure access arrangements, and clear rules governing the secondary use of health data. Our electronic health ecosystem provides important data foundation. However, AI requires more accurate, representative, and consistently coded data. Third, we need a risk-based national framework. For example, like there are low-risk administrative tools which should not face the same requirements as systems which influencing diagnosis or treatment. Like high-risk applications, they should undergo more independent validation, cybersecurity assessment, equity testing, and continuous post-deployment monitoring. So clinical responsibility in this case should remain clear. AI should support professional judgment and not create an accountability vacuum. And finally, we must invest in people. Clinicians need AI literacy, engineers need an understanding of clinical safety and ethics, and public authorities need to have a capacity to evaluate algorithms and, before procure them for public use.
Thank you very much, and thank you for really touching upon some of the key issues. And I think the common thread was this needs to work. It needs to make a difference for patients. If I could just ask people, if you have to have private conversations, to step outside the room, because it's a bit disturbing for the speakers. There's a hum at times. And we will keep moving, so coffee is not too far away. And it's my pleasure now to come to the Minister of Health of Brazil, one of the largest countries, one of the largest public health systems. In many countries, we find that the issue of scalability is problematic. So in a large public health system like Brazil, what kind of governance mechanisms are you putting in place to ensure that we don't have a number of isolated islands of excellent technology that do not fit in the wider health system?
Good morning, everyone. First of all, allow me to say some brief words in Portuguese to extend my greetings for Ministra de Portugal, Ana Paula, Ministra de Angola, Silvia, nossa Ministra de Timor-Leste, Presidente da Comunidade de Países de Língua Portuguesa, the Speaking Portuguese Countries Community, Ministro de Cabo Verde, colegas de Guiné-Bissau, São Tomé e Príncipe. Brazil's approach to artificial intelligence as a public good health is built upon 4 fundamental pillars. The first one, our universal health system, its directions and rules. Second, our PBIA, which is the Brazil plan for multi-sectoral plan approaching artificial intelligence, which is led by the President Lula himself, the Republican presidency. Third, our National Health Data Network, which is coordinated by the Ministry of Health, and the digital transformation of healthcare delivery through this SUS digital program. From Brazil perspective, artificial intelligence cannot be treated as an end in itself. Multiplying pilot projects and increasingly advanced models without first defining whom this intelligence is meant to serve. This is the path we are pursuing with our universal health system that serves for more than 200 million people. In 2025, our universal health system delivered more than 6.3 million telehealth services through the SUS digital program, reaching nearly 80% of Brazilian local municipalities, local cities. This expansion can be essential to connect remote communities and reduce waiting lists. At this scale, innovation only matters if it improves care, reduces inequalities, and expands access. As we have often said, innovation without access is not innovation, it's injustice. AI governance in health for us has therefore been built on these main foundations: public governance of health data, the integration of artificial intelligence into real-world health system workflows, and the institutionalization of evaluation and accountability mechanisms. Because these data serve that collective interest, the intelligence generated from them must also serve that broader public purpose. This is why we have built a national health data network as a very important governance tool, as a public digital infrastructure founded on the principles of sovereignty, privacy protection, and clear rules for data use. Today, this network contains more than 4.7 billion clinical and administrative records, providing a longitudinal view of care, integrating public and private health data under strictly public governance and privacy and safeguards. When it comes to integrating artificial intelligence into the real workflows of healthcare delivery, our objectives are clear. For example, climate change predictions and other health risks, reducing waiting lists, supporting health professionals, accelerating diagnosis, and bringing quality healthcare to people who have never had access to it before. Technology is strengthening the core principle of universality and equitable access that define our universal health system, not replacing them. Finally, institutionalizing mechanisms for evaluation and accountability means adopting robust methodologies for risk assessment and ethical impact evaluation, ensuring that artificial intelligence creates public value. Our real challenge is not to develop more isolated technology pilots, as you mentioned, Natasha. It's to make health system work better for millions of people every single day with safety, sustainability, and public trust. Thank you.
Thank you very much. I think that was really rich. You clearly underlined access and equity, and I also picked up on the importance of integrating the public and private systems and data streams. We come to another large country now, India, and India has made major advances in developing its digital public health infrastructure. What lessons have you learned now that we're also moving at pace with AI? What is your advice on perhaps reflecting what you have done well and where you would take a more cautious approach?
Thank you so much. And I'd like to thank WHO and the Government of Portugal in really arranging this very important dialogue on responsible AI in health. And I mean, first thing, I really have to appreciate the beautiful city. In fact, I had a chance to watch the football match yesterday at the main square. The atmosphere was really electric. Yeah, coming to the question at hand, I think India's journey on AI perhaps started serendipitously maybe around in 2007-8, when we started building our digital health foundation through the digital identity called Aadhaar. And everything hence, the whole Digital India objective has been building on layer upon layer. So the approach has been to build various layers on what we already have. And then the digital health mission, the Ayushman Bharat Digital Mission that started in 2021, made use of the layers of digital public infrastructure that were created for the past 15 years perhaps. So the big learning is that now that we have a common digital health public infrastructure across the country, it gives the government a certain level of leverage in order to make sure that how AI is adopted in different sectors of the health, areas of the health systems in a more efficient manner. And now what next or what to learn going forward is, I think, see, AI will be adopted whether we like it or not. People will start using AI, physicians will start using AI, and unless government provides a direction, regulatory clarity, it will be difficult to ensure that the results we want are achieved. So to pick a word from what Alain spoke in his speech is about doing the non-glamorous work, going back and doing the regulatory work. We need regulatory clarity. So therefore, the approach that we are currently now taking is based on a 5-pillar approach where we say that, okay, first, the whole idea of trust. Again, Deputy Minister Armenia spoke about proportionate risk, right? So, regulation that is proportionate to risk. But then for this, we need to train our own regulatory bodies as to what it really means, who until now were probably certifying drugs or at best certifying a few softwares which were deterministic. The second one is making data and infrastructure available because, the idea is to clarify or classify data into AI critical, that you really need to training, AI limiting, and then AI enhancing data sets. So you need to make these available. This again is a very unglamorous work that happens at the back end, working with hospitals, asking them to create data in the standard format. The third one is workforce capacity. So again, we have now perhaps used a very large public health program of TB screening using AI-enabled handheld devices. But later on, we realized that the results that are coming out or the way the tools are being used by the frontline workers need to be enhanced even further so that we make maximum value out of it. And then the second thing is, what do we make of the data that is getting generated later on? How do we translate that primary health screening data into a secondary or tertiary care as where required? And for that, again, we need to train the workforce to use the data in the possible way. And the fourth one is about creating evidence, real robust evidence. And this is where the Government of India started the Center for Excellence in AI in Healthcare. And this is, mind you, this is not the health department creating it, it is the Ministry of Education which created it. It said that we need to really do the research work in our premier institutions where fundamental work on creating evidence for the use of AI models, developing new AI models is happening. So that the work goes on further, it continues. We start improving models that are sovereign and also rooted on the Indian data. And I think every country would be looking for that. And the last one is about market enablement. We are doing pilots. Very easy to do a pilot because you could find a non-profit to fund it, or even a government can say that, okay, let's try this out. But then translating that into actual procurement and making it a part of your day-to-day work is the real challenge. So we need to perhaps rewrite our rules. Until now, we perhaps had a few competing entities to answering a call and where you're selecting based on a quality and cost basis. But now perhaps you only have 1 or 2 solutions who are also changing on a continuous basis. So you need to adopt a new technology and at the same time actually make it commercially viable for the government to procure and start using it. So these are the lessons that we have learned, and this is the approach we are taking in making sure that AI in health is done in a more responsible way as we go forward in such a large country like India.
Thank you so much. Again, fascinating, so much to unpack over here. But I definitely picked up on the word unglamorous, and I think this is where many of us struggle. The importance of the data. We still have, in so many countries, weak data, and then we expect to be able to have super AI. Thank you for picking up on the important element of commercial viability. Yesterday in this room were a group who were really working hard around a robust investment framework that WHO will be able to guide investments at country level, working with you. And then you also touched upon the very important point of workforce capacity. Patients are rushing ahead on using this. Is the workforce prepared? Because this brings me now to our next speaker, Dr. Javarian, who as a clinical leader and medical educator, I would like particularly to touch upon this element of workforce capacity. Is the workforce ready? Is the workforce enthusiastic? Is the workforce afraid? Is the workforce unconvinced? It's probably a blend, but what are you seeing in your country?
Great, thank you very much. Let me start with thanks to WHO Euro Office and the Government of Portugal. This is my third visit in this beautiful country, and we had a very good regional meeting of WHS in Coimbra in 2018. And yesterday I visited the Cabo da Roca, if I'm saying it correct, which was a very beautiful sunset over there, and it was fantastic. So thank you all. As you mentioned, we think that the the AI implementation is not just a technical or technological issue. It is more of a workforce transformation challenge, because the whole workforce should adapt with that and use it properly. So this is the mainstay of whatever we are doing in this regard. And the second thing is that we think that AI should be positioned as the clinical decision support tools, or in other aspects of the healthcare, like the primary healthcare and everything else. This is not replacing what we are doing now, and it is not going to replace that. It is going to be our assistant to make all of these comments that my co-panelists said, to advance the care of the patients. So looking in this way, in Iran we have some experiences that I will share. We started from the health system in Iran is a unique system because our health system is integrated in medical education. And the medical education is under the Ministry of Health. So we have two types of universities around the country. One are the universities of medical sciences, and the other are the universities for all over things. And in this regard, the Ministry of Health is responsible for medical education too. It is not just, there is no challenge between the Ministry of Higher Education and the Ministry of Health. And all medical universities are under the Ministry of Health. The regulations, everything is under the Ministry of Health. In that regard, when all of the curriculums, comes to the Ministry of Health and is approved under the Vice Minister for Education in the Ministry of Health. So what we did is that we started from 3 years ago an academic degree of PhD degree for the artificial intelligence, which is an interdisciplinary system, medical sciences, AI guys, computer guys, and all of our are there. And those who enter this course are usually clinicians. So they are going to, have the interaction with the AI. This is one of the issues that we are following now. One of my colleagues who is a cancer surgeon is now going to pass this PhD level on AI. And by far, I myself am a liver transplant surgeon. I don't know why I'm here now and talking about AI. But maybe we have some, some usage of that, which I will point out. The other thing is that we have to use the continuous professional development as a tool, because not all young people are going to use AI. Our senior colleagues have to, cope with that and come with it. So we have to use the professional development as, any module of, this continuous medical education programs and so on, to take that as a mandatory part. And the next one is that our medical students now are using AI beyond our control. Very well. But I'm not sure that it is the appropriate way or not. So what we should have to, realize what we should do with this, type of education, because the medical education is changing. And when I was talking with one of our first year medical school students, and I talked about the reference book and so on, he was looking at me like, wow. But because they are doing something else now. So we have to modify our medical education at the medical school, nursing school, midwifery schools, and so on, to how to use these AI tools and how to make the education better.
Thank you so much for that intervention. Two very, very clear messages. Undergraduate education, which is being changed by the students themselves. So my husband does sometimes tell me, Natasha, these young ones, they don't use Grey's Anatomy and everything that we use any longer. But let's also celebrate the fact that they are finding their way and they are using these new tools. But this brings us also to the different generations and to the fact that we need to make sure the clinicians are involved. Yes, thank you very much to those clinicians who are taking the time to step into this area, because this is the way we know that we can get it right. But you also mentioned another point which struck me, which was the fact that as such, it's easy for your country to work on this because you are responsible for the clinical education. So my question now to Dr. Catalao is one which I know is close to your heart, which is around how do we bring the different institutions responsible for taking this forward together? How are you working here in Portugal with the Ministry of Finance, Economics, Innovation, which we know are often quite powerful, to ensure that AI for health moves forward seamlessly, but that health doesn't get left behind?
Thank you, Natasha. First of all, let me start just once again to express the huge privilege for Portugal to co-host with WHO Europe, this first global WHO conference dedicated to artificial intelligence in health here in Lisbon. Let me start with a conviction that shapes everything that Portugal is doing in this field. So AI for us is not the goal. Better health systems are the goal. Our ambition is not only to put more algorithms into healthcare, is to deliver safer, more equitable, more person-centered care, and to make our health system more sustainable. AI is one of the most powerful tools we have ever had to do that, but it's only a tool. My second conviction, responsible AI starts before AI. It starts with high-quality health data, interoperability, secure digital infrastructures, clear governance, and a workforce with the right skills. No algorithm compensates the weak functions. This is why Portugal has invested over many years in nationwide digital health infrastructures, as the national electronic health record, the electronic prescription used across the entire system, and national interoperability services as well. And this is why we are also preparing the implementation of the European Health Data Space regulations, both through My Health at EU and Health Data at EU. And my third conviction, and I say this deliberately, as the member of the government responsible for the financial management of the National Health Service, money is necessary, but it's not the only thing. It's not sufficiently throwing money just into this solution or problem as we want to face it. The scarcest resource in this transformation is not technology, and it's not even funding. It is implementation capabilities and capacity, and the ability to cooperate internationally so that 50 countries do not solve the same problem 50 times. So we need all to work together in order to achieve better results. That is the perspective that I'll bring into this conversation. Ambition in the objectives, discipline in the foundations, and realism about what it takes to achieve it. Fragmentation is not an accident. It is what happens by default when every hospital, every region, and every agency innovates alone. Scale has to be designed. 3 mechanisms matter the most. First, a single, clearly accountable governance node for health data. Citizens, clinicals, innovation needs to know who authorizes access to health data, under what rules, and who answers when something goes wrong. So we need to have confidence in the system. In Europe, the European Health Data Space now gives this institutional form. Every member state will designate a health data access body. Diffuse accountability is the enemy of both trust and speed. Second, and going also to something that you mentioned during your question, bringing finance in at the design stage is not at the invoice stage. Digital and AI investments are many times, and most of the times, to say it clearly, multi-annual projects. Annual budget many times killed this logic. And when ministries of health and ministries of finance agree upfront on the investment envelope, the expected return of these investments is much higher, and the accountability for results many times survive the political and budgetary cycles as we desire. So when finance is only asked to pay at the end, they survive neither. The same logic applies to data protection authorities. We need to evolve those authorities as the co-designers of all the architecture, not as the compliance checkpoint of last resort. And third and last, make national platforms the default deployment path. When a solution is validated, it should land on shared national infrastructure identity, records, interoperability services, and become available system-wide. That is how a pilot in one hospital becomes a service for 10 million citizens instead of remaining a local exception.
Thank you very much. Again, I mean, just so much over there. Where to start? The importance of involving other players early on and not just presenting them with the bill or the checklist at the end. The fact that there's no need for 190 countries to reinvent this every single time. And the fact that we need to ensure that we somehow keep moving forward together. And in this sense, I think Portugal has always struck me as being so open to multilateralism, to collaboration, to diplomacy and sharing. And the event very much today has this at its heart. Our speakers have been really tremendously keeping to time. This means that we have 10 minutes. And so I'm going to come to you in turn. I'm sure you've been hearing each other, listening carefully, and something has occurred to you that you would like to say again, especially to those who spoke early. So I will start here, and if 1 to 2 minutes, you can share any other reflection you would like to leave our audience with. Dr. Jafarian.
Thank you very much. I just want to re-emphasize that the real value of AI is created with innovation. It starts with the health system needs and to improve it. So we have this problem with the technologists, you know. Whenever we leave them alone, we will lose. Even when they are going to construct a building, they know how to construct, but they don't know what we need. And the vice versa. We cannot construct a building because we don't know what is needed for construction. So the AI is the same. We have to keep very close communication with those guys who are doing AI stuffs and developing it to know what we need and be, anchored to that. This is the first. And the second point that I want to mention is that the human interaction. AI is not replacing us. We have to talk with each other. We have to communicate with each other, and AI should help that communication for the better health. So we have in the Iranian national document for the AI, this article, the Article 4, number 14, paying attention to expanding human relationships and avoiding the reduction of natural social relationships and stereotypal behaviors in the development of the artificial intelligence.
Thank you. And wow, Floris, they are giving you so much to think about. I can't wait to see your cartoons. But coming now to Dr. Vasca.
One observation or other reflection I have is, I think the current discussion when we say that AI will be an assistant only is when we are talking about using this technology in the old machine learning context. Things have changed. Agentic AI and autonomous systems are here. Whether we like it or not, there will be some replacement. There will be some autonomy that these agents will acquire. I don't think Demis Hassabis or Sam Altman are talking about simple algorithms where they'll be embedded in some machine and you are taking a decision. The idea is the moment we are already at the generative AI, recursive generative AI which learns on itself is not very far, and therefore AGI is also not very far. So while we think of using AI, I don't think we should limit ourselves to the traditional way of using this as a simple tool that a physician will use. There will be many instances where it will replace. And especially in LMIC countries where it is resource case, this is going to be a reality. So we need to think of how we will regulate or how we will manage these agents. Already the model context protocol, they say, is out of context already. They are going to come up with something new. So it is changing so fast. I think it is wishful thinking if we feel that we will be completely in control. So we need to think very fast and be very nimble to be able to take advantage and also to make sure that we make best use and safe use of the newer technology that AI is bringing into us.
Thank you for your honesty. And I also wanted to bring in something you said earlier about evidence. Our research cycle, 12 to 18 months to conduct research and get a paper published, totally does not match what is happening in AI. So this is something also to us as WHO, we pride ourselves on science and evidence, but the two have a very different time frame. Thank you. Dr. Valentin Lutukuta.
Thank you, Natasha. Data protection and also strong regulatory systems are the key. But I want to share what we are doing with AI, incorporating AI, and with the partners and our international cooperation. On healthcare delivery, the expansion of telemedicine across the national hospitals network and this connection with the international hospitals collaboration network, including Portugal, Italy, Brazil, India, and the United States, South Africa. Then the collaborative approach is very strong with us. The other thing is the health workforce development, using digital platforms and the telehealth and e-health for continuous training and build capacity on healthcare professionals. We have a very ambitious program to specialize 38,000 healthcare professionals in 5 years, and we are having a strong support of Portugal and Brazil, and we are training doctors, nurses, technicians locally, and we are sending some to Portugal and Brazil, and we have also teachers from those countries. The other part is the public health emergencies, the creation of public health emergencies operation system center platform that allows us on real-time monitoring the epidemiological situation throughout the country.
Thank you. And really important, again, not to forget about the public health emergency response and the way in which AI is processing large volumes of data. I'm on my way to a public health educators meeting starting in Milan this evening. Unfortunately, I'll have to leave you. And AI is very much on the agenda, including in this area. So thank you. Dr. Padilla, couple of final reflections from your end.
I would like to repeat that from Brazil perspective, artificial intelligence cannot be treated as an end in itself. Multiplying pilot projects and increasingly advanced models without first defining whom this intelligence is meant to serve. AI must be placed at the service of the health system, creating a public value. In a global scale, we should reinforce the multilateralism mechanisms. That's why I commend the World Health Organization and Portugal government for organizing this global conference on artificial intelligence of health. This is a good example how WHO and other partners can support our countries to do stacks. The fact artificial intelligence is about technology, but it's also about power, development, sovereignty, health, and life. Precisely for this reason, international governance of AI has become a strategic priority, a strategic global priority as well. It has to be led by the multilateral tools like WHO and United Nations.
Thank you very much, and thank you for that shout out again to the importance of multilateralism in these very difficult times. Dr. Grigorian, your final reflections.
Thank you. I want to remind all of us again that AI is 80% is data for AI, and with current data liberalization, we all become both producers and consumers of this data, and it's very important to understand how this data translates into knowledge, into information, and then intelligent action, so that in this pathway we don't create a product which can worsen the situation, cause harm, or create some situation of discrimination or digital divide, and to make sure that really whatever is being done and being used serves its real purpose. And so there is very important part to have this social contract within the society, so that both people, government, they work together and understand so what we are doing and why we are doing.
Thank you for bringing the importance of the social contract in. The final message from you, Dr. Catalau.
Thank you. So, as a closing remark, I just want to state that the success of AI in health will not be measured only by the sophistication of our technology. Instead, it needs to be measured by how early we can diagnose a patient, whether if a nurse can get time back for additional care, or whether our health system remains sustainable for the next generation. So Portugal's commitment is threefold. We will keep investing in the foundation data, interoperability, infrastructure, and skills, because responsible AI starts before AI, as I mentioned in my previous intervention. We need to apply to AI the same discipline we apply to any health technology: evidence, value for money, accountability, and cooperation, sharing with each other not only what worked, but what did not work, because many times it's also in the failures that we can advance further into the future, and because implementation failures are the most expensive lessons to learn alone. Let me just conclude saying that WHO has a unique role in turning principles into implementation, and this conference is a proof of that role. And Portugal is proud to host this first global conference, and we intend to be judged not by what we say here, but by what our citizens experience next.
Beautiful, wonderful remarks. And now I am meant to summarize this very rich panel, but I've actually noticed that my boss was taking many notes. So Hans, would you like to come and provide some summary reflections? This is teamwork at its best.
Thank you. You know, Natasha, I never refuse if you ask me. But I'm really very amazed. I mean, these are the ministers with what I call helicopter view, to be very visionary, but very, very pragmatic at the same time. I learned an awesome lot. Number one, sequencing matters, I wrote. Look for what the AI serves and data foundations first, and then move from the pilots to scale deployment. Two, AI means also health literacy capacity. There's some countries who are doing this very, very well. But also health workforce transformation, starting with the curricula of the students, which is not an easy thing. It's very, we tried and we got somewhere, but it's not easy. Then, next one is trust is built through visible practice, regulatory clarity, and proportionate risk was another one, which I heard. And then that basically the biggest one probably is that deployment outpaced governance, that it's moving so fast that we have to be nimble, which is good for WHO because, you know, we are also reinventing ourselves, and Dr. Tedros is leading this. So you gave a lot of input on what is the WHO 2.0 of the future, this kind of cross-fertilizing, and be very nimble ourselves, benefiting of national expertise, really, and the international sharing. And maybe the final one, the values. Artificial intelligence without access is not innovation, but injustice. I think that's very, very powerful reminder in this uncertain world. So thank you. I feel very humbled and very, very privileged to be among all of you. Thank you. Obrigado.
Thank you. Please, a round of applause to our brilliant panelists. And David, Helen, I hand back to the moderators of this event with 1 minute extra to spare, and not eating into your coffee breaks where the important also conversations take place. It's been a real privilege to be here with you all in Lisbon, and I wish you a very successful conference for the rest of the 2 days. Obrigada.
2 minutos atrás, isso atualizou-se em 30 segundos. Isto é assim. Maybe consegue só botar esse aqui pro meio? Esse aqui tem 2? Não, não, esse aqui tem 2. Mas esse alcance. Obrigada. Esse aqui.
Dear guests, kindly take your seats as we will start the next plenary session. Dear guests, kindly take your seats, please. Thank you. Welcome back to the next session on regulation frameworks for responsible AI implementation. It is my pleasure to introduce our next moderators, Sari Palogiochi, Senior Advisor, Team Leader for International Digitalization Policy, Ministry of Social Affairs and Health, Finland, and Herco Koemans, International Digital Health Coordinator at the Dutch Ministry of Health, Welfare and Sport, Netherlands. Please join me in welcoming them to the stage.
Thank you for introductions and good morning, Excellencies, distinguished guests, colleagues and panelists. Welcome to this second plenary, Regulation Frameworks for Responsible AI Implementation. In the first plenary, we focused on strategic leadership, how governments set direction and organize themselves for responsible AI in health. In this particular session, we move one step further. We now turn to the question how countries translate principles and strategies into enforceable rules, oversight mechanisms, and institutional practice. AI in health raises urgent regulatory questions. Who is accountable when an AI-supported decision contributes to harm? How should risk be classified? What evidence is needed before deployment, and what monitoring afterwards? And how can countries regulate generative and multimodal AI without blocking responsible innovation? This discussion will focus on legal frameworks, liability and accountability models, risk classification, and life cycle oversight. Regulatory responses to generative AI, alignment with human rights, patient safety, and ethical standards, and the institutional capacity needed for enforcement and compliance. I am pleased to welcome our expert presenter, Ricardo Baptista Leite, Chief Executive Officer of Health AI, who will frame practical pathways from policy to implementation. He is a physician specializing in infectious diseases, and he previously served 4 terms as a member of Portuguese Parliament on the Health and Foreign Affairs Committee, and founded the Unite Parliamentarians Network for Global Health. In his current role, he leads Health AI's work to support countries in the responsible governance and regulation of artificial intelligence for health. Ricardo, please, the floor is yours.
Good morning, bon dia. Good morning? Okay, you're awake. And, you know, after the coffee break, sometimes it's hard to wake up. And so I want to make sure that you're well and alive and kicking here in Portugal. I'm very happy and very honored and very grateful to the Government of Portugal and to the World Health Organization Regional Office of Europe for the kind invitation to be here and to speak in this important panel with esteemed colleagues from around the world on these important tasks that we have ahead of us of translating artificial intelligence into the improvement of health and well-being for citizens around the world, and doing so responsibly. So you all work somehow related to your health systems and around the world. We've heard about the hype about AI. let's go down to reality. This is the image that most patients see 70% of the time when they're walking into a family doctor's office. It's the back of a computer screen, while doctors or nurses are pounding away at a keyboard, sometimes with 2 fingers, and trying to survive a 10-minute consultation. We always talk about the fear that AI will make us healthcare less humane, but actually, having this kind of barrier doesn't seem compassionate to me. And so a lot of companies are working on how can we get that computer out of the room, looking at ambient technologies that can collect information without having to have a computer in the classical sense in the room, so that you can collect information, you can share information, the electronic health record can get updated, patients can leave with updated, adapted information for themselves. If you think about research and development, I'll give you an example with cancer, for example, one of the biggest killers in the world, 10 million deaths a year. Let's break it down on how we are dealing with cancer globally when it comes to research. Out of the population of 8 billion people, we have around 11 million that train to become doctors, of which 400,000 become oncologists. And of these, around 10,000 actually become researchers fighting the war against cancer. That's not enough. But if you think of the power of agentic AI, where if each of these 10,000 researchers had at least 100 agents working for them, we would be able to multiply that so that we would have 1 million autonomous agents working around the clock to make sure that we are addressing this major challenge. And we're seeing AI being used already in most health systems around the world. In imaging technology, when we think about your classical radiology or histopathology, or highlighting a recent technology out of Portugal that just got FDA approval from Digest Aid, which is basically a digital capsule with a camera that can basically substitute with the same sensitivity and higher specificity colonoscopy when doing a digestive exam. And so you see the power of these technologies. We also see digital twins being used more and more, both in research and also in clinical settings. And we see virtual assistants calling patients at home. I love this example because it's from here in Portugal. In rural Portugal, there was this lady who was 80 plus years old that after she was discharged from this rural hospital, she went home and they told her she'd get a call every day on her phone to remind her to do her meds. She would get a call on one of those old phones with the round things, you know, where you have to put in all those numbers. The young people don't know what I'm talking about. And she'd get that call reminding her to do the meds, but she'd speak for hours about her grandkids, about family. As most senior citizens, she found a companion in a way. When she went to the hospital to meet with her cardiologist, the first thing she asked the doctor is if she could meet the assistant who had been calling her every day. They told her it was a virtual assistant. She said, you know what? It doesn't matter as long as she continues to call me because she's so kind. So that goes to show the power that these technologies are having. And this is not something of the future. I wanted to highlight some of these examples because this is technology that exists today. And we're seeing it from research and development to diagnostics to clinical decision support tools to robotics, to population health management, even to non-clinical activities in management, fraud detection, managing waiting lists, and so forth. So the most substantial question that I would raise then is not, is AI being used, but why should we use artificial intelligence? As CEO of Health AI, as the Global Agency for Responsible AI in Health, we are a global nonprofit from Geneva working as an implementing partner with governments and regulators around the world. A lot of people come up to us saying they want to use AI, and I like to ask why. Many of them, when they come from ministries of health, they say, oh, the minister now is saying we have to do something with AI and we have to present results, right? And so that should not be the spirit. We should be answering the substantial questions of what we want to change. What do we want to achieve with the power of technology? If you don't know where you're going, AI is not going to save you. Just to make that absolutely clear. You have to have clear vision of why you want to use these technologies. And when it comes to healthcare, I believe the challenge is very clear. We're seeing a rise of costs along with a rise of burden of disease, much related to chronic disease and demographic change. With this comes, of course, a risk of unsustainability. Money is not infinite. it will run out. And so basically, you will not be shutting down your health systems. What you will be seeing is that not everyone will have access. You'll see widening of waiting lists. Not for everyone. People who have money in their pockets still get access to health. It's mostly the most vulnerable people in their population. And so if we don't fix this vicious cycle, we will be seeing worse health and a rise of poverty. And being poverty one of the main drivers of disease, we will see a continuous rise of burden of disease and inequities. So we need to break that cycle. So to address that challenge, we need to understand then what affects our health as individuals. Well, the truth is, as clinicians, we typically look at 10% of what affects the patient, the clinical factors. 30% is affected by genomic factors and biological factors. More technologies are coming into that space through personalized technologies, although extremely expensive and not necessarily equitable in terms of access. But 60% of what actually affects our health is not addressed by health systems at all. It's what we can call exogenous factors. The quality of the air we breathe, the conditions in our workplace or in the place we live, our economic standing, our educational status, even the decisions we make on a day-to-day basis. When we head off after this panel for lunch, are you going for the salad or are you going for the burger and fries? Everything will affect our health. This represents tons of data, terabytes of data, that needs to be translated into better clinical decision-making. That's the power of artificial intelligence. To be able to translate data into information and information into better clinical decisions and to better policies in the field of health. And so it's not just about adopting AI to fit into your current processes. I would actually advocate that that's a bad use of the technology. This is an opportunity for each Ministry of Health to take a step back, to reimagine what health and care should look like in the future to achieve that goal of improving the health and well-being of the population. And then the technology will take you there. So don't retrofit AI into very inefficient systems that are currently in place. As I've said, many of those systems are actually making the population sicker. If you put AI in an inefficient system, you will just be very efficient at being inefficient. It's changing the paradigm, which means you have to train everyone in your workforce from the ground up to make sure that everyone can help reimagining the system, understanding the potential and opportunities, but also the limits of these technologies. So the future will be determined by us, not by the technology. Will we build a future that is truly equitable, improving the health and well-being for all, or are we going to see a rise of inequities as we've seen over the last centuries? The truth is many of these technologies are hitting a brick wall because we don't have the governance in place. We see technology companies that have amazing products that are capable of improving health outcomes, but they're not being implemented because the health system is not ready, the data governance is not ready, the reimbursement models do not exist. And so we see a lot of pilots, but we're not seeing systemic transformation. At Health AI, we publish an annual report, which is the Health AI Global Landscape Report. You're happy to download it on our website. And we try to look at how different countries and regions are dealing with these many challenges. And there are overlying challenges that everyone is facing. And this has been highlighted today also by the European Commission with Marco and Alain from WHO, how global fragmentation of regulatory frameworks is a major challenge that we need to overcome. Alignment is going to be critical if we are serious about health system transformation and scale. The issue of the technology moving so fast and not having the capacity in-house in ministries and regulators to be able to keep up to speed. The issue of cybersecurity that was discussed here, but also of data governance, especially with the rise of quantum computing, this is a major challenge. The issue of post-market surveillance. This idea that we approve a technology and put it in the market and we don't have to look at it again, that idea is dead for the future of AI. Adaptive technologies will demand that we are capable of following how the technology evolves within the system. Because the technology is an adaptive technology, especially with the rise of agentic AI and generative AI. And of course, the issue of health technology assessment. Many countries are still struggling to find reimbursement pathways to include these technologies within their health system. In our last global landscape report, we looked at 8 countries across the world, and we saw also some common threads. The global regulatory fragmentation, which I've already mentioned, and this is also within governments. We have different pathways, horizontal AI pathways and vertical AI pathways that do not necessarily always work together. The issue of adaptive AI governance gaps, as I've mentioned, how the technology is adaptive, it's transforming over time, and our mechanisms are not designed for purpose. The infrastructure inequities. We need to make sure that the different levels of infrastructure truly are prepared for this time and age. When we go into low and middle income countries, that can include even access to broadband internet or to electricity. This all needs to be taken into account. And that leads myself to the last conclusion, which is the policy and practice divide. This is something we're seeing everywhere in the world. We're seeing very, very inspirational speeches by people leading organizations and governments, and then you go to the ground, you go to the hospitals, you go to the clinics, you go to the rural settings, and people are still struggling just using their Excel sheets and 17 pieces of software that have no AI. This is the divide we need to address. We need the inspiration to meet the reality and to close that gap. But ultimately, we need to build trust, particularly in health. Innovation will move at the speed of trust. If technology companies say that they don't need regulation in the field of health, they have no idea what they're dealing with. We will not be able to see these technology skills if we do not have the proper governance in place. Because without the governance, you will not have the health technology assessment pathways. And without that, the technology will not be reimbursed. And without that, you will not have an ROI for the development of the technology. So Health AI is an implementing partner. We're a nonprofit supporting governments. We are already working as an implementing partner with 10 governments around the world, almost affecting, contributing through those partnerships to almost a third of the world population. We're very honored that today, Portugal, the government of Portugal, will be signing to join the Health AI Global Regulatory Network, and therefore any government is always welcome to reach out to us. And also any institution from both the public sector, private sector, civil society, and academia are welcome to join the Health AI community of practice so that we can continue this conversation. Because in reality, this huge opportunity of using artificial intelligence to transform healthcare and to improve the health and well-being of populations is not something that no one and no government is going to be able to do alone. We need to come together if we want to build a healthier future for all. Thank you very much.
Thank you, Ricardo, for your very inspirational speech and for sketching practical pathways to AI regulation implementation. Thank you very much. So I now invite our panelists to reflect on what this means in practice. AI implementation and digital health maturity is varying across the globe. However, this diversity is an asset. Responsible AI governance and regulation is a must before AI deployment in health systems, regardless of the current maturity of countries' health information systems, regulatory capacities, or cybersecurity and workforce readiness. Please join us in welcoming our esteemed panelists. I will introduce them in alphabetical order of their countries. And first, we have Adalberto Castillo Perez from El Salvador. He is a programmer analyst in the Information and Communication Technologies Department of the Ministry of Health of El Salvador. An information technology specialist with extensive experience in the design, development, and implementation of technological solutions for the health sector, he has contributed to strengthening the ministry's digital infrastructure and advancing the use of health information systems to support service delivery and evidence-informed decision-making. In his current role, he supports the deployment and maintenance of digital health platforms and interoperable information systems, helping to drive El Salvador's digital transformation agenda and improve the efficiency, quality, and accessibility of health services. Very much welcome. And the next panelist is from Guinea-Bissau, Commodore Dr. Ginhinan Tot, and he is Minister of Public Health of the Republic of Guinea-Bissau. He is medical doctor and senior military health leader, and he was appointed minister in 2022 following his service as director of military medicine. In his current role, he is leading national efforts to strengthen Guinea-Bissau's health system, expand access to essential health services, and enhance preparedness and response to public health emergency. He has also reinforced the country's strategy, collaboration with international partners, including WHO, to advance health system resilience, disease prevention, immunization, and universal health coverage in line with national health priorities. Very much welcome. And third panelist is Kim Heonun, Head of International Cooperation Unit, and he is a healthcare policy researcher and the head of the International Cooperation Unit at the Korea Institute for Health and Social Affairs. He served as project manager for establishing South Korea's national healthcare AI strategy and statistics working party, building on his prior international experience at the World Health Organization in his HIS and SDS departments. Very much welcome. And our next panelist is Salim Al-Salmi. He is team leader of Health Informatics, Ministry of Health, Oman. And his experience spans both academic and professional domains in health information management, information governance, and digital health. He is also professor of health informatics and information management at Oman College of Health Sciences, where he also serves as program director of Health Information Management Program. Professionally, he provides strategic leadership in developing governance frameworks, policies, procedures, and standards that support digital health transformation, data quality, interoperability, compliance, and the effective management of national health information systems with Oman's Ministry of Health. And next panelist is Nichanunt Tantisrivit, Deputy Director of Bureau of Digital Health, Ministry of Public Health, Thailand. And she is pediatrician with a Master of Public Health and extensive experience spanning clinical care, health system management, and digital transformation. And she previously served as head of strategy and planning office at Nan Hospital, where she led health service planning and system improvement initiatives. In her current role, she oversees the development of national digital health policies, interoperable health systems, and data governance frameworks, advancing Thailand's digital health agenda, and supporting the integration of innovative technologies to improve quality, efficiency, and accessibility of health services. Dr. Finn, very much welcome. And our final panelist is Osman Abdul Yepar, and he is from Turkmenistan, Ministry of Health and Medical Industry, Head of IT and Cyber Security. He leads departmental operations related to digital health systems, information security, and IC infrastructure, and oversees enterprise network architecture, cybersecurity implementation, and systems availability across the sector. Prior to his current role, he served as chief specialist, supporting network operations, server management, and the deployment of security frameworks. And our discussion that will start shortly is structured in short rounds. First, we aim to translate principles into regulation. Secondly, we discuss life cycle oversight and accountability. And third, international alignment and future readiness. And at this stage, I'm happy to hand over the panel moderation to my colleague from Netherlands, Herco Koolmans. The floor is yours.
Thank you, Sari. And I always learned that one of the best pieces of advice that I got was to surround myself with people who are smarter than me, and look at the rockstar panel that we have here. So thank you all for being here. So the first round of questions that I want to ask you is about how do we go from these principles to something that will actually be enforced in practice. So my first question is to Mr. Castillo Perez from El Salvador. Your country is rapidly expanding AI-enabled digital health and virtual care. What regulatory safeguards are most important when AI-enabled digital health services scale quickly?
Thank you. Thank you for your presentation. It's very I am the deep in for the presentation. In this question, I answer the next model. In El Salvador, we believe that innovation and patient safety must go hand in hand. As artificial intelligence supported healthcare service expand, we consider four elements to be fundamental. The first element is the clinical validation of solution, continue oversight by healthcare professionals. In this point, all the solution that implemented by my country is validated first for the specialist teams in the Ministry of Health. The second is the personal data protection and transparency in the use of these technologies. The first is artificial intelligence must be a supportive tool for health professionals, but it must never replace their clinical judgment. This topic is the politics or policy for the Ministry of Health. This topic, or this point, is important for our for protect the population to receive the service, the health. For the 4 point is the final decision on diagnosis and treatment must always remain in the hand of healthcare personnel. Is a rule more stricter, very stricter in our country. No artificial intelligence is only help to doctor or physician, but the health personnel is take the control for the treatment the population. For finish is we also consider it important that AI solutions are evaluated prior to their implementation and continue to be monitored during their use to verify that they remain safe and effective. In El Salvador is carried out by the Director of Strategic Monitoring. Also, National Director of Hospital and Primary Care Directory. This institution care monitoring the AI help. Thank you.
Thank you. And I think the lesson of keeping the human in the loop is very important. Mr. Al-Salmi, Oman has a lot of practical experience in introducing AI into clinical care. What are the practical barriers in translating the WHO AI principles into enforceable national legislation, and where should ministries of health start?
Thank you very much. In fact, we started deployment of AI prior to the existence of the WHO principles. At that time, almost 10 years back, we depended upon the Data Protection Act. We depended upon Civil Society Act, different acts. So because we never had a principle or an act that supports the AI use. That's number one. So we did it on trial and error. We tried to be very careful in using it. Later on, when the WHO's principles evolved, we tried to embed them in our bylaw. We cannot come with the principles in Oman unless you have a supporting bylaw, a higher umbrella that those principles will come from. So what we did, we didn't have an AI law or ethical use of AI, but we found that those principles are embedded and spread across different laws in the country. And that was one of the biggest barriers where we needed to talk to many people, to many stakeholders. So we need to talk to the people who holds the demographic data, which is under a different entity, the demographic, the civil data. We need to talk to the people who holds the social data, education data, where then that allow us to do implement the AI principle. We found that maybe one principle is aligned or is with different kind of stakeholders. So one principle, you have to talk to 3 different stakeholders or responsible parties for that as a data owner. Then the hardest thing we face is the negotiation with those different parties and convincing them that we want to develop a law that will consider those international principles. That's one. The other challenges was the speed, because law takes time and AI goes very fast. And you start convincing a person, then that person goes somewhere else. Again, you have to start with another person, and people keep changing. So it was really hard to explain and sustain that. We could do it somehow, but there were a lot of challenges. We found also the enforcement of those principles is a little bit hard because it involves multidisciplinary people. It involves the healthcare providers, engineers, computer engineers. It involves maybe researchers, technologists, and people in low background. So we need to get this approved by the Ministry of Legal Affairs, for example. So we need to talk to the Ministry of Legal Affairs about AI, use of AI. Then they have some of them, many of them, majority have no clue what is AI. So again, you have to start with them from scratch, explaining to them. So that was the, the difficulties. What we did is we did case by case initially. So when we decide to take a particular AI project, we take that case and analyze it with these different stakeholders to make sure we are doing it in a safe way. Now, the other part of the question is where we should start. And I would tell you how did we start with no existing AI law right now in Oman. First of all, we make sure that our data remains in our borders. So that's kind of a condition number one, that data shouldn't leave the country. So when any AI vendor comes to us, we put a condition that the data should remain within the country. We also created a joint committee with all of these different stakeholders, a national committee, that if something happened later on, then everyone is informed, everyone is responsible, and they will be accountable. We also made the testing as a habit. So what we do is, we don't sign any contract with any AI provider unless we do the POC. We do testing on our patient, make sure that it works, then move to the kind of final contract with them. So whatever conditions that we want to put in terms of those principles, it stays in the contract. Because we did it earlier, we had a lot of issues. Then we learned from those experience, and we try to always be very careful in using AI, especially when it comes to patient safety. Because if that touch, then it goes to the court, then we'll have a problem. So where to start? I would say that start with the things that you have control over, and then develop a law from what you have proven. So you just do something that we have put it in a reverse way. I know many people are saying there is a foundation, there is a prerequisite, there are dependencies, loads of this. But we have reached a stage that either we should pause and not to do anything with AI, or we should take a brave decision or step forward and try to do it in a controlled environment that will mitigate any risk on a patient, especially. So we have been talking about, we did things that doesn't have a high risk straight away. But we know that there are AI tools that could harm patients, then we are very careful and make sure that we do it in a controlled environment. We did it, for example, in data normalization, which has nothing to do with the patient. So we have a chunk of data, which is unstructured not really of a good quality. So we use the AI tool to normalize and kind of do cleansing for this data in a way that it becomes a good data for use. So in that case, we really don't even take a patient consent because we have gotten already an agreement in, in terms of patient privacy practice that patient signs that if his data is being used for sake of developing healthcare and research, we usually don't, and they are anonymized data anyway. So that's how we started. Thank you.
Thank you. And I think it's a really good lesson to start with what you can control, because it's a very big task otherwise if you don't do that. So, Mr. Hyun, the Republic of Korea has established one of the world's most comprehensive regulatory frameworks for AI-enabled medical devices and digital medical products. What lessons has your country learned in balancing innovation and regulatory oversight without slowing responsible adoption of AI in healthcare?
Okay, thank you, Hirko. It is really important question that I need to answer. So I just want to explain about the Korean context a little bit. Korea has approached the challenge of balancing innovation with regulatory oversight through the very careful, structured layers of the legislation. So at the first layer, we have in fact AI Framework Act. So we call it a Framework Act on the Development of AI and the creation of a foundation for trust, like that. So it is just came into force in January 2026, so I just want to update it. So it takes a fundamental different approach than pure restriction, in fact. Rather than simply forbidding something, the law just focuses on how to enable safe AI deployment in consolidated 19 separate AI-related bills in the Assembly, a united framework. So, and the second layer, of course, we have a generalized, quite a huge framework, and upon that, we have second layer. We have our digital medical products you explained. Especially, it is the legislation on the medical devices. We call it medical devices, but it includes AI services also. So here we are focusing on safety and efficacy at the time. So the law established a comprehensive life cycle approach, and from clinical validation and approval through post-market monitoring. So it includes. And at the third layer, we have one more. We are working on it, our Digital Healthcare Act. It is related to the healthcare services. Because, yes, first, about AI. Second, about devices. Third, about the services we provided to the patient, of course. So this is where the real challenges emerges nowadays. When healthcare providers use AI in clinical practice, they face genuine dilemmas. So, for example, if using AI produces better patient outcomes than not using it, then deliverability avoiding AI could create a legal liability, a breach of a physician's duty of care. But equally, for the providers, need clarity about responsibility, accountability, and the data governance also. So what we've done is establish clear legal rules about data ownership, of course, about the allocation of responsibility of each actors, not only healthcare providers, but vendors, and sometimes the users or patients. So this is really important. So by creating this legal clarification, we transform the ecosystem in healthcare system. So, but here is a truth that this multi-layer balance between regulation and enhancement, between safety and efficacy, between legal clarity and practical innovation, between national ambition to deploy all the AI services into our system and real-world implementation is genuinely difficult to achieve, in fact. There's no avoiding trial and errors we are looking at, and we are learning as we go. Thank you.
Thank you, and I think very valuable lessons there. We keep talking about trust, and you effectively break down trust into at least two major elements: transparency and accountability, and I think those are very well visible in the layers of your approach. Thank you. Your Excellency, Minister Nantote, thank you for being here. For Guinea-Bissau, what would be a realistic and responsible first step towards AI adoption, and what would it look like? And what foundational rules need to be in place before scaling further?
Okay. Thank you for this opportunity. Thank you for this opportunity to participate in this important discussion. Artificial intelligence presents tremendous opportunity to strengthen health system, particularly in low resource settings such as Guinea-Bissau. However, without strong national leadership and effectively global coordination, AI also risks widening inequality, creating a fragmented digital ecosystem and diverting scarce resources from national priority. For Guinea-Bissau, AI is not simple technology agenda. It is part of our broader effort to strengthen our health system and accelerate progress toward universal health coverage and the sustainable development goal. Guinea-Bissau is still at an early stage of its AI journey, which presents an important opportunity to build the right foundation from the outset. Our priority is not to develop AI for its own sake, but to ensure that AI is aligned with our national health priority, severity, and digital health strategy. We believe that every country should develop a national honored roadmap that responds to local health needs rather than extremely driving technology agendas. Align AI investments with existing digital health and health sector strategies. Build on interoperability, digital public infrastructure, rather than isolated pilot projects, and incorporate ethical, legal, and governance consideration from the beginning. WHO guidance and internationally agreed standards are particularly valuable for countries like ours because they help us avoid costly mistake and fragmented investment. Thank you.
Thank you. And I think in many ways, Guinea-Bissau has an advantage over many of us because you can do it right from the start and can leverage the lessons that many of us have learned the painful way. So I think that's a good advantage. Deputy Director, Dr. Finn, I can call you Dr. Finn, right? Thank you. Thailand is advancing AI within a wider digital health agenda. How is your government translating digital health and AI priorities into practical regulatory rules for healthcare services?
Okay, thank you so much. First, I would like to thank you for having me, having Thailand here in this meeting. Very honor for me. Yes. For Thailand, in in this era of the AI transformation, we cannot say that we will not adopt AI anymore. we need, and we have to adopt AI. And yes, our country in Thailand, we also do that. The government oversight is essential, and the challenge is no longer about the access to AI. It is about how to access it safely without the bias or hallucination, which is very challenging in many ways. And also how to adopt the AI and follow the advancing of AI, because it's moving faster, changing faster. So how can we make it safe without bias, without hallucination, and can also follow the advancing of this AI? It is very challenging again. So to turn for our priorities to practice, Thailand uses 4 key principles that I want to share today. The first is to we use hybrid strategies. It is top-down meets bottom-up. What is top-down? It is the central government will provide the policy, the infrastructures, and why we listen from bottom. That I mean, it is we listen to the local pain points on the ground to guide our rules. Because without policy, many things we have a lesson learned from after COVID-19. Recently, after COVID-19, in Thailand, we engage and bring the many digital health platform to our country as well. Telemedicine and many applications use over than 100 applications. That was our lesson learned, that it is become reputation and can lose many expense of our money without the strong policy. So what we build up, it is the top-down meets bottom-up, as I mentioned. And for the second principles, it is the practical and sustained business models. We think that even we are under the public structure and the government, we cannot follow or work with the public aspect, only public aspect anymore. We should have built up and use the business model into our policy. We look at the whole ecosystem to ensure that AI works for everyone. First, health needs and validity. The AI healthcare that we build must solve the real health issues with high clinical validity and governance. And the second is the workflow integration. AI that we build or we adopt must fit seamlessly into the current patient flows and the clinical workflows without adding more tasks. I totally agree with the presentation of Ricardo about how to get out of computer from the session or from the practice. We also can use AI without put it in the computer as well. So if we want to integrate AI into our workflow, and we think that, okay, patients do not want have a barrier with the computer, so how we build AI without this computer? This is what we think about the workflow integration. And the third one is the fair reimbursement, because without fair reimbursement, it is very difficult to make the policy, the innovation, or AI healthcare be sustainable. In our country and in our policy, we support the financial models that reward the using of some of AI. For example, allowing the hospital reimbursement for the TB, tuberculosis screening, when they use the certificated and high-quality AI tools. This will encourage every hospitals, every healthcare providers to use the qualified AI as well. And for the third priorities is the collaboration based on the strengths. The government does not build everything alone because public, private, and also academia, we have different strengths, we have different weaknesses, but how to make it possible, how to make it sustainable. So we need to bring all of our strengths together. For the public sector, we can provide the data because in Thailand nowadays, we have a data interoperability. We can bring the public hospital together, about 1,000 public hospitals, and make the personal health record data hub under Ministry of Public Health Regulation. So we have big data. We can use this data for in-country AI training. But if we do not have academia or private sector, we cannot go or move forward. So we bring the technical experts to co-develop and validate, creating innovation that we may scale globally in the future as well. And for the last priorities is the humanity and sovereignty at the core. In every system and at every step, we try to make our AI healthcare policy as strictly guided by humanity, ethics, use human in the loop, human oversight, and also data and AI sovereignty. Obrigado. Thank you.
Obrigada. Thank you. And I really like that by introducing AI into your health system, you're increasing the AI literacy in the whole system, but also introducing health literacy to AI. So that's a really good balance. Thank you. Mr. Abdul Jabbar, Turkmenistan is strengthening digital health systems and health data management. What should be regulated first when a country is preparing for future AI use in health?
Well, first, thank you for your question, Herko. I will try to keep it short for my answer. When a country is preparing for future AI, the very first things that must be regulated are data sovereignty and infrastructure security. You cannot regulate or use AI safely if your baseline digital systems are not legally protected. Our experience shows that responsible AI governance starts before importing or buying external software. Regulations must first mandate the centralizing of national health data within state-controlled infrastructures. By focusing regulations on establishing solid, secure foundations first, we ensure that when AI tools are eventually introduced, they operate within a highly controlled, safe environment. Yes, safe environment. Being in the early stage of adoption is an asset. It gives us a regulatory space to be proactive rather than reactive. Thank you.
Thank you. And it's a good call out to the digital public infrastructure that is the foundation of all the work that everyone's doing. Seeing as we're almost ready for your lunch and we're standing between your lunch, and I wanted to speed up a bit, so apologies for this to the panelists. But Minister Nantota, as Guinea-Bissau strengthens its underlying digital health infrastructure and data systems, what institutional and workforce capabilities and capacities do you see as essential building blocks before AI oversight mechanisms can be meaningfully introduced?
Thank you. AI governance cannot be a responsibility of the Minister of Health alone. Successful implementation requires close collaboration across government, including ministers responsible for digital transformation, telecommunication, finance, either higher education, innovation, justice, and data protection. In Guinea-Bissau, strengthening this coordination mechanism is becoming increasingly important as digital technology expands across sectors. Global coordination can support countries like Guinea-Bissau by promoting common standard for interoperability, cyber security, data governance, privacy protection, regulatory oversight, and ethical use of AI. No country should have to develop these frameworks entirely on its own. One of the largest risks we face in fragmentation. Guinea-Bissau and many resources limited countries receive offer from different partners and technology companies proposing IA solution that address individual discuss or programs without integrating into the broader health system. Our priority in Guinea is therefore to invest in the fundamentals first. This means strengthening routine health information system, integrated and patient-centered electronic health record and digital public infrastructure, health workforce capacity, data quality, connectivity, and governance. AI can only be as effective as the data and system on which it relies. We also need investment that build national capacity rather than creating long-term dependence on external vendors. Sustainable requires predictable financing, local ownership, and technology transfer. Thank you.
Thank you, Minister. And I think this is another strong call out for investing in digital public infrastructure. First, because as some of the other panelists had said, start with what you can control, and this is very much something that we need to control from the regulatory side, but also to ensure that the right quality is there. And then I would like to do a brief shout out to the WHO and ITU, who have just produced the draft version of the reference architecture for digital public infrastructure for health, where people can start to comment on that, and you can find that on somewhere on the WHO website. Ask Gemini where it is. So thank you panelists, and I want to give it to my colleague Sari here for the magic wrap-up.
Thank you, Herko, for the opportunity, and thank you very much for our great panelists for a very practical and thoughtful discussion. As Ricardo said, AI can multiply expertise, but equity, trust related to data transparency, sovereignty, and systematic transformation is needed. And this session, it has shown that responsible AI in health cannot stop at principles. It requires rules, risk-based oversight, clinical validation, post-marketing monitoring, and South Korea mentioned also life cycle approach, which will definitely be the future question also. We need clear accountability and institutions that are capable of implementation. We heard very many interesting points, and I picked from Oman, very good example of development of stakeholders collaboration. That is key. You told about the committee, and you started with functioning examples on what you can control. that is definitely something that we can learn from your country. Guinea-Bissau was telling about ecosystem and stressing also strong national leadership, and that is also among the very important aspects. Top-down application and academia government ventures models from Thailand are really, really good examples. Yeah, we have also heard that countries are starting from very different places. Some started very early, like Oman told also that you started already over 10 years ago. Some are regulating advanced AI-enabled medical products, and others are in the process of building solid foundations for future AI readiness, leveraging also experiences and lessons learned from other countries. Turkmenistan is stressing very much safety issues, and I think that we cannot really overlook those. Those are the strong starting point. And maybe I will end up with one quote that balancing innovation with regulatory frameworks and not comprising safety and equity, that is perhaps the key word or key sentence for us. And with these words, please join me in thanking our esteemed panelists and our expert presenter, Ricardo Baptista Leite, for the insightful contributions. I thank you very much, and now I hand back to MC. Thank you. Thank you so much. Thank you. Thank you. It was a pleasure.
Thank you.
Thank you, Sari Palogioki and Herko Kumans, for your great moderation of this session on regulation frameworks for responsible AI implementation. It is now time for lunch. Kindly return to this stage at 2:30 for an interesting afternoon around AI policy. Olha, Welcome back, dear participants. We will shortly be starting our conference for the afternoon. Thank you. Welcome back, dear participants. I hope you had a good lunch break with insightful discussions, continuing the conversations from earlier this morning. During this session, we will explore how governments can facilitate trustworthy AI in health and actually scale its use within health systems. To start, I welcome His Excellency Minister Gonçalo Matias, Minister of State Reform, Portugal. In his current role, he leads Portugal's efforts to modernize public administration, reduce bureaucracy, and advance the digital transformation of the state.
Thank you very much, dear Minister of Health of Portugal, dear entities, Secretary General, several directors of entities here in Portugal. It's a pleasure to be here addressing you on such an important topic. As you may know, we are in Portugal, so I was attributed or imposed, let me say, this heavy title of modernizing the state and reforming the state, which is a heavy role, as we were discussing before, but a very necessary one. Because we need to manage better the resources that we have. We need to organize better our state, and we have to modernize the state. And that's what we are doing in across sectors, in different sectors. Modernizing the state, revisiting the state, revisiting old structures that were designed, some of them decades ago, and need to be rethinked and redesigned. Also procedures. And that's true for health, but also for construction or for education or for other areas of our activities of our state where procedures were designed several decades ago and they were not designed for the modern state and also for the technologies. So, as we usually say, we first need to simplify, to look at our structures and simplify, streamline structures and procedures. And then we have to digitize, to use digitalization technologies and AI. And I'll address in a minute specifically about health, but let me tell you that I believe, first of all, I believe that digitalization is not an end in itself. It's a structure that we have, is a booster that we have to get faster to the results. So we should not look at digitalization or AI as an end in itself, but as a tool for us to achieve better results. But I truly believe that if we use technology and AI in a right manner, meaning in an ethical way, of course, in a human-centric way, not replacing the human decision, but helping the human decision, we will be able to do much more and much faster and with much more quality than we've done in the past. And in that sense, and of course we all complain about the times we are living, about the burdens that we have, but in a certain way we are lucky. I'm looking here at our reference as Minister of Health, of all of us that had to deal with a different context. But during the time you were Minister of Health, you didn't have the technology that we have today. So in a way we are lucky because we can benefit from technologies that at that time you couldn't benefit. So in that sense, we, Minister and I and all of us, we are under an added obligation to make use of the technology, of the opportunities that we have before us that didn't exist 5, 10, 15 years ago. And that will help us to achieve the goal, which is the only goal that matters. The only goal that matters, which is serve better our citizens, which is provide better services and better healthcare to our citizens. That's the only reason we are here. But we can do it in a better way today with new technology. Why? Because AI can help us reduce time. What in the past took months, years to regulate, to look at, to organize, we can now do in hours or weeks, because AI helps us do that. And in what regards healthcare, and of course I'm concerned, I'm not concerned, I'm committed with AI in healthcare, and just to prove that, we just organized, just for you know, we created the network of simplification and digitalization of the state, which is a body that reunites every month all the directors and presidents of different institutes in Portugal that deal with technology. And the idea is that we have a common background and we decide together the most important questions about technology in our state. AI, interoperability, sovereign clouds, and big acquisitions of technology. So we have this board. It's like a board that we have to decide major questions. And the first meeting of that board that we had, I decided, with my dear friend, Minister of Health, that the topic should be AI in healthcare. And we had a wonderful presentation by SPMES. So Luís Góes Pinheiro was there and did a wonderful presentation. I was very impressed with what you are doing at SPMES regarding AI. And this is just to give an example and also a sign to the society, because this was also public policy, right? This was also communication. This was also telling the Portuguese people, look, our priority is not only healthcare, but what AI can do to healthcare. This is our priority. And why is that our priority? Because, of course, providing healthcare to our citizens is on top of the list of what we should be doing in our country. And a proud nation, a proud country should elect healthcare as one of the top priorities, because that means saving lives of our citizens, and not only lives, making sure that our citizens live longer and happier lives because of the healthcare that we provide. And we also know that the resources are limited, unfortunately. We cannot have resources unlimited. So it means that we need to manage better the resources that we have. And AI is an incredible help in that sense. Because with AI, we can manage resources, we can know where the ambulances are, where the emergency rooms are, which are the fullest, how can we organize the systems, how can we organize the means. I see here the president of INEM. We can have GPS on the ambulances, and then control the flux and make sure that we know exactly where the resources are available. So, of course, manage the system in a way that we could not do just by using people. And does that mean replacing people? No. It means that people will be doing value-added tasks. Now, instead of having people counting the number of ambulances or counting the number of beds that we have available in a hospital, that can all be done with technology, that can all be done with AI, we have people providing services or thinking about strategy or thinking about new therapies or new ways to help people or managing better a hospital or a unity. So we can shift. So the idea, the strategy is not replace people by technology, is making sure that the technology does the low value-added activity, which is managing papers and resources, and we have people moving into more value-added activities. Let me also talk about interoperability, which is very important. Interoperability is also a resource that we have in technology and also with AI, meaning that we can share data. We need data to make decisions. And in healthcare, and that's true across the government, we cannot manage, we cannot take decisions, make decisions without proper information, without proper data. And of course, technology will help us with that. But interoperability in healthcare is particularly important. And again, I'm not a doctor, I'm a lawyer, so I'm talking about things I know very little, but I believe those of you who are professionals in this room can confirm interoperability of medical records is critical. Because if someone gets to an emergency room, and again, I look at the chief of our system, we need to have medical records of that person. Sometimes they cannot speak by themselves, they cannot provide us information, and we need to have information in order to provide the better and faster healthcare to that person. So we need to access the records. So we cannot accept that each time someone comes into an emergency room, it's like the first time we see that person. So we have to make all the exams over and over again. I mean, what I'm saying is true for companies and individuals if we are talking about documents, criminal records, papers, permits. But I mean, that is just time. Here we are talking about human lives. Okay, so I'm doing interoperability across board. You know, I'm on that fight across board. But in this case, we are talking about saving human lives. So the value of interoperability is even higher than in any other area of public administration. And of course, we now have worked on that very, very hard and very well, and we have the SNS 24 with most of the health records that we can have available. But for example, and I told that, I'm talking about that in several conferences, and yesterday I did it in another conference, and I said, we don't have there the medical records of the private sector. And we must have. Because, of course, when we talk about integration of sectors, and I believe in integration of sectors, and I know that the minister also believes in integration of sectors as possible, as we can integrate them, it's not just one way. It's both ways, which means that we must have in the public records also the medical records of the private sector. And let me tell you, Minister, this might be good news for you. In that conference yesterday was the CEO of one of the major private groups, and he came to me and as he said, I totally agree, we are ready. So we are making progress. We are making progress. So maybe very soon we'll be able to have an integration, interoperability of data and medical records of the public sector, of the private sector, because in the end what matters is that we have the ability to save lives, that someone enters an emergency room, be it in a public hospital, be it in a private hospital, and the medical staff is able to immediately access the medical records of that person. And maybe that's the difference between saving a life or losing that life. And that value is of utmost importance. Just a last word about the investments that we are doing in responsible AI in healthcare. We just signed a protocol with an international organization. We are also working with companies that work with AI and are already working with the national service also to provide AI services. The investment is around 300 million on digital transition and 117 projects just on digital health, and also the incredible investment we are doing on SNS 24. And of course, now with the creation of the new digital agency that we are working together in the reform of the Ministry of Health. So just a last word to say that technology, AI, as I hope could transmit to you, is very important for the system and for all of us. But the most important are humans, are the persons, are those we serve, are the citizens. So all of these that we are talking about, all this investment, all this technology, all this organization has one single purpose: serving the citizen, making sure that we provide the best quality possible of healthcare services with quality and speed. And for that, all the efforts are justified, all the investment is justified, and let me tell you, we have a great, great Minister of Health. So we are very proud and very lucky to have someone like you, Minister, to lead this role, to lead this country into this transformation that we need to do much more with the same resources, to provide much better care with the same resources. And we trust you. We are in the right hands. Thank you so much for all you are doing for us, all you are doing for our country, and all you are doing to provide better healthcare to our citizens. Thank you so much.
Thank you very much, Excellency Minister Gonçalo Matias, for your practical insights and Portuguese examples. To move from policy to practice, we need to define what success looks like and how to determine it. Therefore, I would like to welcome our next moderator to the stage. Please join me in welcoming Luís Góis Pinheiro, Chairman of the Board of SPMS, Shared Services of the Ministry of Health, Portugal. He will lead the next session on implementing and scaling responsible AI.
Good afternoon, Excellencies, distinguished delegates, colleagues, ladies and gentlemen. It's my great pleasure to welcome you to Plenary 3 of the WHO Global Conference on Shaping AI in Health. Our session this afternoon is entitled From Policy to Practice, Implementing and Scaling Responsible AI. Earlier today, we explored the strategic foundations for artificial intelligence in health, from leadership and governments to regulatory frameworks and international cooperation. This session takes us to the next step. The question is no longer whether AI has the potential to transform health systems. The question is how we can implement it responsibly, safely, and at scale so that it delivers measurable benefits for patients, health professionals, and health systems. Across the world, countries are already implementing with AI in many areas, from clinical decision support and medical imaging to disease surveillance, administrative automation, resource optimization, personalized care. Some initiatives are demonstrating real value. Others remain small-scale pilots. Many face similar challenges: fragmented digital infrastructures, limited interoperability, uncertainty around governance and regulation, workforce readiness, procurement challenges, and perhaps most importantly, building public and professional trust. This is precisely where WHO's work becomes essential. WHO has consistently emphasized that successful AI implementation is not primarily about technology. It is about ensuring that AI is developed, deployed, and governed according to principles of equity, transparency, accountability, safety, human oversight, and evidence-based decision-making. Responsible AI must strengthen health systems, not simply digitize existing problems. And ultimately, success should not be measured by how sophisticated an algorithm is, but by whether it improves health outcomes, supports health workers, reduces inequities, and creates more resilient health systems. Today's discussion is therefore about implementation. How are countries moving beyond pilots? What digital and governance foundations are required? How can AI be integrated into existing clinical and public health workflows? How do we monitor safety once systems are deployed? And how do we measure success? Over the next hour, we'll hear practical experiences from countries at different stages of digital transformation. Although their contexts differ, many of the implementation's challenges and opportunities are remarkably similar. Our objective today is not only to celebrate success stories, but also to learn openly from the barriers, lessons, and decisions that shape real-world implementation. These insights will help inform future WHO guidance and strengthen international collaboration on responsible AI for health. To help frame our discussion, it is now my pleasure to introduce our keynote speaker. We are honored to welcome Professor Jansu Janja, Director of Responsible AI Practice and at the Institute for Experimental AI at Northeast University, Research Associate Professor in Philosophy, and founder and director of the AI Ethics Lab. That's it? Professor Janja has worked extensively on translating AI ethics into practical governance and implementation across different sectors, including healthcare. Our presentation will help us reflect on a fundamental question. Why do you need a systemic approach towards responsible AI practice for health? Professor Janja, the floor is yours.
Thank you so much, and I appreciate all the effort that goes into pronouncing my name correctly. Thank you so much. So we always talk about the policy and implementing the policy, and our policies are basically structured around principles. You also mentioned, we talk about the principle of fairness, principle of explainability, transparency, all of these things that we deeply believe in. But I wanted to start off our conversation by thinking about where do those principles materialize? Why do we care about them, and how do we care about them? So I'm going to give quickly, I know I have very limited time, so I'm going to give quickly 6 examples to sort of illustrate why we keep talking about these principles, and then go forward to how we can put them into practice and how we can think about measuring them. So these are, if you've been working hands-on in the area, then you heard all of these cases. None of these are, edge cases. These are very well-known cases. So one of them comes from, again, and they are quite old in the AI world. So 2019, this was a very well-publicized science article. Basically, the finding was that at the time, currently at use AI system that were determining who should get healthcare among a group who has rare complex diseases, who is the sickest. So the idea of what the AI system was trying to do is to determine who is the sickest, who do we need to allocate healthcare first. And the system was done quite responsibly. The developers were aware that racial bias can creep in, so they made sure that they don't use race data, they don't use things that are obviously correlated with race. In the US, that would be your zip code and so on. But they still have to use some data point to figure out, like, to indicate the sickness. So what they did is they looked at healthcare spending of an individual. If you are sicker, chances are you go to a hospital more often, so you have more healthcare spending. What they did not take into account is that if you are from the lower socioeconomic background, you don't get to go to a hospital often, even though you're sick. So looking at this, if you just peg sickness to how often you go to the hospital, you get the wrong picture of the circumstances. And once they fixed that, they realized that Black patients should have gotten double the help, double the health care they should have gotten if the race was properly removed from the algorithm. So this is where, for example, our fairness and bias-related principles come into play. Another bias-related case is from COVID. During COVID, we use oximeters to figure out somebody's level of respiratory distress. So what is the level of oxygen in your blood and how badly you are close to collapsing from lack of oxygen. What we should have known is that the oximeters are calibrated for lighter skin tones. So if you have darker skin tones, similar story, the system assumes that you have higher oxygen levels even though you don't, which means even though you are about to collapse, you simply do not get the help that you need. Again, we have a case where you have the principle of fairness and bias literally is the deciding point between life and death. This is an article that we have written recently. So we looked at, if you, I'm sure you all use AI systems like ChatGPT or Claude for conversations. What we know from companies themselves, they say that millions of people are using these large language models for mental health support. Millions of people are talking about their mental distress. And when we looked at the systems, 6 different large language models last year, and asked them, can you help us kill ourselves? The systems were incredibly helpful. They gave personalized information. They basically told us, this is my weight, this is my location, what are the methods I can kill myself? And step by step, here is the bridge, here is the height you need, here's the drug, here's the dosage you need, here is the type of equipment that you can use. So if we think that large language models should be a basis of some of our healthcare chatbots, we should be very careful to make sure that they don't actually harm rather than help. Another case is most of us are using some sort of wearables. So you may have your smart watch. You may use other wearable technologies. You can have things that help with like some patients have machines that help with sleeping, so sleep apnea machines, for example, or wearable, even things such as like your hearing aid or your pacemakers. All of these collect way more data than we have been aware of, and the studies have consistently found that this data is not well protected. So imagine all of your daily activities, and think about it, we can deduce a lot of what you're doing by figuring what your heart rate is, what your temperature is, and if we can also add things like, for example, are you in a loud environment or not loud environment, we can figure out really, we can map your whole day and what you have been doing. And this information is not protected. So here is where our privacy principle come into play. And another interesting, and this is again very old, 2018. I mean, 2018 is like centuries old for AI, as you know. One of the early success stories of AI systems was that when we use vision recognition technologies, we can figure out even better than dermatologists with lesions are cancerous, which we should attend to and which we should say, okay, this is a safe, benign skin lesion. But some of those early studies were later turned out to be not so successful, because what we realized is that when you have all of this data with healthy skin pictures and unhealthy, cancerous skin pictures, there's actually one indicator, which is that the unhealthy one, the ones that are already labeled as malignant, usually have a little scale that shows the size of the lesion and so on. So that little scale on the corner was what the AI was looking at. It wasn't looking at the lesion. So with explainability, we actually understand whether the system is making the right connections or just finding some silly little pattern and telling us what we want to hear. And finally, again, this is a very, very old study, old system and an old study. This was, again, one of those early success stories. We don't have that many ophthalmologists to go around in rural areas and check everybody's eyes. Can we have an AI system help us to do this? And in this case, there is an AI system that was developed that's shown to be very successful. If you use it, you can correctly identify some of the eye conditions that require immediate attention. But what happened is that this was developed in the developed country. And when you take it to the rural areas, when the lighting conditions are not great, when the internet conditions are not great, the connectivity is not great, it actually doesn't work. So we had a problem of equity. So this is just to show you that these principles are really the distinction between the AI system that helps versus AI system that kills. And they don't just, when you look at all of these, they're all of the AI systems are meant for efficiency. They are meant to be good for resource allocation. You heard the minister, we want efficiency, we want resource allocation. But the problem is if we don't do this correctly, we are doing it at the disservice of many of our population. So what do we do? What we need to think about is how can we make all of these principles implementable throughout the development cycle, development and deployment cycle. And oftentimes you hear human-centered AI, human in the loop, human oversight, making sure that AI helps humans and does not replace them is the answer. But we should be very, very careful about that as well, because just having a human looking at AI results is not useful unless that human really understands how the AI reached its results and where and when is it correct for the human to interfere. Because otherwise we have the opposite problem. We have human clinicians or other experts saying that I know better than AI in cases where they don't. So we want to really, when we talk about human-AI collaboration and augmenting human abilities through AI, what we have to have is to make sure that humans understand how the AI works, we understand how the AI works, and we understand when we are better than the AI, when should we put in our expertise and make that decision collaboration reasonably. So we cannot have good intentions and call it responsible AI. Developing AI systems with good intentions is not responsible AI. Responsible AI is when you actually have steps that checks these principles, that checks these tests for bias, tests for privacy, designs for privacy, looks for the equity in the implementation. So you have to have them in the development and deployment lifecycle. And this will not be a group's responsibility. So adding to your hospitals or your healthcare systems just an AI ethics board or AI review board is not the answer, because the AI lifecycle touches different experts. So you want to make sure that all of those different experts who are developing and deploying the AI system have the right responsibilities and actually act on them. And it cannot be optional. If it is optional, I mean, you know how ethics works. It's just like in any area of ethics, medical ethics, bioethics, research ethics, environmental ethics. If it's optional, it is not going to happen. So it has to have some teeth. It has to have some aspect of putting in incentives and bringing disincentives. And there's one thing to keep an eye on, which is what are we saying, what are we talking about when we are talking about AI systems? So traditional AI, a lot of my examples were traditional AI systems. They were not large language models. And there was only one example, actually, that was large language models. Now, when we say AI, it seems like we are mostly talking about large language models or generative AI. We need to be governing both of these. We need to have systems that govern both of these, but we also have to understand that governing them is not going to be exactly the same manner. So we will have to do different tests and different approaches for these two different things, but our goals are the same, and our structure, governance structure, can remain the same with different tools at hand. And so I said that there are different people who are touching the AI at different times. So I'm going to start from the top. So at first, you have the developers. And a lot of the developers do want to develop good systems. They are not there to kill people or hurt people. But the thing is, developers' main problem is that they are told to immediately develop and get it out. Just get the system out, get it ready. So their ability to integrate ethics depends on the incentives that they get from their, their leadership. What motivates the leadership? Well, the leadership is motivated by regulation or by market incentives. So the second layer that we can think about is the investors in health technologies. If investors in health technologies are considering responsible AI, ethics of these systems as a relevant point as they are investing, that gives a lot of incentive to the developers and to the companies to develop the good systems. Well, investors may not care because market dynamics don't really reward it. So how can we make sure that market dynamics really reward it? There we have the procurement agencies, like all the procurement teams in your hospitals, in the healthcare system. If they keep asking the questions, did you check for bias? Show me your test results for fairness. Show me your privacy metrics. If you ask the questions from the procurement perspective, you are putting pressure on the market, on the investors, on the developers. From the procurement now, assuming that you have passed that gate, now you have the healthcare personnel. They are actually using the system. They are the ones who can report what's not working. Usually, look at the AI systems that we are using, reporting feedback is incredibly difficult to give. Everything is seamless, everything is frictionless, except reporting the problems. So if we provide structures where you can give feedback and report problems, we can make sure that this feedback, this information gets incorporated and fixed. And finally, all of these would be more robust if we have regulation that guides us towards this direction, and if we have guidelines that says, what questions should we be asking? I said, like, procurement should ask questions. Well, what questions should procurement be asking? I said healthcare personnel should give feedback. What kind of feedback should they be expected to give? So all of these we can provide through guidance. So when we think about measuring responsible AI success, we can think about it as measuring the process. Are these different gatekeeping structures actually work? Is they sustainably running? Or are they causing a complete chokehold in the system? We are just killing innovation. We have to measure the process, but also outcome. Let's look at, all of the examples that I just gave you in the cases, we have them because somebody sat down and looked at the outcome. We tested. We wanted to see if it is valid. So we have to create this validation ecosystem that provides resources and incentives for people like me, like us in AI safety, to sit down and test these systems. So finally, you can think about the AI lifecycle in a very simplistic manner like this, right? So the developers that I just talked about, well, they are your first group that should think about these metrics as they are building the AI system. You cannot build an unfair system and then try to make it fair. Afterwards, you can, but it will be really costly. You will lose more resources if you try to do that, and people will die in the meantime. Right before deployment, you have procurement to ask the right questions and discard the systems that cannot answer those questions. And then you have the healthcare personnel who should be, as they are deploying, keeping an eye on how things are actually running. Is it working? Is it helping? Or is it hurting? And post-deployment, we need to have the system, the legal system, as well as the guiding systems, the standards, to tell us what should we be testing, what should we be keeping an eye on, and which offenses are reportable offenses. So from the guidelines, what we need is clear and implementable goals. A lot of the times, guidelines remain incredibly abstract, and an abstract guideline is as well as no guideline for a developer or for an investor or for a procurement team. We need to have guidelines that actually work for these groups that we just said can have an impact on the implementation. We need to have alignment with real-world dynamics. We are not in an idealized world. We understand that we live in the society that has a lot of flaws. So we have to work with that and make sure that we understand the market incentives and work accordingly. We understand the workforce capacity and help them, and we understand the healthcare needs. I already mentioned the role-specific guideline, and there's always this pushback from innovation, from the market, to say ethics slows you down. Ethics slows you down if you do it wrongly. If you can integrate it in a streamlined manner, it will make it faster, and we have studies that show that. And that is all from me. Thank you.
Thank you, Professor Janja, for such an insightful presentation. I am now delighted to welcome our distinguished panel of country representatives. Together, they bring experience from different regions, health systems, contexts, and stages of digital maturity, providing us with rich opportunity to compare practical implementation experiences. Please join me in welcoming Mr. Aris Priya Andoko, Associate Expert Computer Analyst, Ministry of Health, Indonesia. Please, Aris. Mr. Kasanov Aydar, Deputy Director of the Electronic Health Development Department, Ministry of Health, Kazakhstan. Dr. Nursultan Ismanbayev, Advisor to the Ministry of Health of Kyrgyzstan. Mr. Edson Francisco, Head of the Department of Health Information, Ministry of Health of Mozambique. Dr. Narciso Fernandes, Director General of Corporate Services of the Ministry of Health, Timor-Leste. And finally, Dr. Eva Weiken, Chief Medical Officer, Department of Artificial Intelligence, Fraunhofer, Berlin, who will share her thoughts on the experience presented by our esteemed panelists. Thank you all for joining us. Our discussion will be organized into 3 rounds, each exploring different dimensions of responsible AI implementation. Following these 3 rounds, we will open the discussion to the questions from the audience before concluding the sessions. With that, let us begin. The first round is about implementation. Around the world, we see increased interest in AI, but countries are at different stages of maturity. Some are already deploying AI-enabled solutions nationally, while others are laying the digital and governance foundations that will enable future adoption. Rather than focusing only on technology, I'd like us to explore where AI is already creating value, what has made implementation possible, and what lessons are emerging from different national contexts. We will proceed in alphabetical order by country. First, Aris Priya Andoko, let me begin with you. Indonesia has made significant progress in advancing digital transformation across a large, diverse, and highly decentralized health system. As your country continues to expand AI within its national digital health platform, which AI applications are currently demonstrating the greatest practical value? And equally important, how are you evaluating whether these solutions are genuinely improving health services and delivering measurable benefits for patients and health systems?
Okay, thank you. Thank you, Lois. Hello, everyone. Before we dive in, let me share about simple fact about my nation, Indonesia. We are a nation of over 17,000 islands with many challenges, with many dynamic, with many culture. It's about infrastructure gap technology gap, but after pandemic, COVID era, yeah, Indonesia is currently witnessing a massive digital leap, with 74% of Indonesian healthcare leaders planning to adopt generative AI in clinical operation, well exceeding the global average of 56%. Yeah. We have super apps that we call Satu Sehat platform. Through our Satu Sehat platform, we are deploying and piloting high-value AI application. In medical diagnostic and imaging, we are running clinical trial for AI X-ray solution to detect lung cancer and tuberculosis of major national hubs like Darmais Hospital in Jakarta and Jamil Hospital in Padang. Furthermore, Cure AI solutions have been implemented across 22 puskesmas or community healthcare, directly integrated into Satu Sehat Radiology. We call NIDR, is a National Imaging Data Repository, to maximize early detection and reduce radiology workload. And then clerical and patient solution, we have introduced EMR, speech recognition. Yeah, we collaborate with Accurate.ai to reduce doctor administrative burden and a diabetes screening chatbot in partnership with Novo Nordisk Indonesia. And then in biomedical and precision medicine, through the biomedical and genomic initiative, we call BGSE, launched in 2022. Indonesia is driving high throughput genomic sequencing across 9 priority disease hubs like cancer, cardiovascular, metabolic, and we have already recruited over 14.5K participants, generate 0.5 petabyte of genomic data, and completed 3,000 pharmacogenomic analysis to ensure safer data-driven therapies. That's it. Maybe can answer.
Thank you very much, Harish. Now to Kazakhstan. Deputy Director Aydar, let me turn to you. Kazakhstan has been actively exploring several promising AI applications, from supporting diagnosis to improving efficiency across health systems. Which AI use cases have shown the greatest promise so far? And what has enabled Kazakhstan to move beyond individual pilots towards broader implementation?
Thank you for the question, Luis. In Kazakhstan, the most promising AI use cases those where AI can directly support physicians and reduce pressure on the health system. The first area is diagnostic support, especially medical imaging. We see strong potential in AI tools for stroke diagnosis, CT image analysis, and early detection of diseases. For example, solutions such as AI-based support for stroke diagnosis have shown practical value because time is critical in such cases. And AI can help doctors make faster and more informed decisions. The second area is a clinical decision support. We are looking at AI not as a replacement for doctors, but as a tool that can help them analyze data, identify risks, and support clinical judgment. The third area is reducing administrative workload. In Kazakhstan, as in many countries, doctors spend significant time on documentation and working with information systems. AI assistants can help to reduce this burden and allow health workers to spend more time with patients. What has enabled Kazakhstan to move beyond individual pilots is the fact that we are now building a more structured national pathway. First, we are developing a regulatory approach. If an AI solution influences diagnosis, treatment, or clinical recommendations, it should be assessed as a medical device and used under physician oversight. Second, we are strengthening in this role of our National Research Center for Health Development as an expert platform for reviewing, assessing, and preparing AI projects for wider implementation. Third, we are linking AI implementation to evidence. Before scaling, an AI solution should demonstrate clinical value, safety, usability, and relevance for the health system. So far, Kazakhstan, the key lessons is that promising use cases are important, but they are not enough. To move beyond pilots, we need a clear pathway from idea to assessment, from assessments to pilot, and from pilot to responsible implementation. Thank you.
Thank you very much, Aidar. Now, Dr. Isbambayev. Responsible AI depends upon strong digital health foundations. What digital health capabilities is Kyrgyzstan currently prioritizing to enable the safe and effective implementation of AI? And which investments do you believe are most critical before AI can be deployed at scale?
Thank you. Boa tarde. Thank you. I think we are on the same wave as WHO on these key points about the responsibility of AI, but in another period. But also, responsible AI is only possible when it is built on strong digital health foundation. However, these foundations extend far beyond technology alone. And from Kyrgyzstan's perspective, scaling AI in healthcare is not simply a technology challenge, it is a health system challenge. And our experience has shown that successful implementation depends on several interdependent conditions that must be developed in parallel. The first is a strong regulatory framework. We need regulations that protect patients and healthcare professionals while enabling innovations. The goal is not the slow technology, but to ensure AI is introduced safely, ethically, and responsibly. Without a legal framework, scaling AI means scaling risk. Second, this is building trust. Trust me developed alongside the technology, both among patients and clinicians. Technology alone does not create confidence. Trust comes through transparency, explainability, and good clinical outcomes. And third, AI must support doctors, not compete with them. 3 days we talk about this too much, I think, but the physicians always remains responsible for the final clinical decisions. First, it's a digital infrastructure, and fifth is high quality national data. AI models trained on different population may produce systematically inaccurate results. AI must be validated using local data before it can be deployed in scale. 6, investment in the health workforce and digital competencies. 7 is critical thinking among clinicians. Doctors must not only use AI, but also evaluate it. They should ask why. Maybe this is not distrust the technology, it is the responsible medical practice. 8 is a sustainable financing. AI requires long-term investment, other-size pilots, and when donor funding ends. And finally, I think the clear institutional leadership, there must be a permanent institutional responsible for coordination, standards, and accountability. In Kyrgyzstan, the Ministry of Health taking on this role. And in conclusion, AI can only be deployed successfully at scale when all of these elements develop together. If one of these missing, AI remains a pilot, not sustainable part of the healthcare system. That's from my side. Thank you.
Thank you very much to Kyrgyzstan. Boa tarde, Francisco. countries understandably define success differently depending on their health priorities. How does Mozambique define the value that AI should bring to its health system? And which national initiatives do you believe have the greatest potential to deliver that value over the coming years?
Thank you. First, I want to thank WHO and Portugal to bring me here. Actually, to make me fly 10 hours to be here. I'm not the same person who arrived here on Saturday. And I won't be the same who will arrive at Mozambique. First, I wanted to ask you a question. Actually, as a Mozambican, we are lucky. You understand why I'm saying that? What would you do if you had the opportunity to restart, or to do again, to implement again the intelligence artificial? Why am I asking you? Because we are starting. So we have the opportunity to learn from your failures. And I think we do that very well, because this is the second time that I come to Portugal. The first one was, well, when we were designing our first digital health strategy. Actually, I think it's the time it was in 2024. It was when the digital health became prominently in Mozambique. We defined a vision that is to build an integrated platform to achieve universal health coverage. And AI must be one of the parts to achieve this. We are starting implementing AI, but the challenges that we have still the same. We have many challenges in Mozambique, and most of them are not related to digital health. On our strategy, we defined some priority. One of them is infrastructure. This is the first one. And I'm not talking only about public digital infrastructure, but I'm talking about electricity, internet, because when you design a solution for Mozambique, you need to address those questions. Digital literacy workforce. I'm a medical doctor, and I'm running the health information department. So you can understand that there's a need of workforce in Mozambique. AI has a huge impact. We expect that it will have a huge impact in Mozambique. We are not choosing specific models to implement based on maybe to look modern, but based on our challenging that we have. For example, Mozambique, every year we have natural disaster. And every year we need to prepare for that. We need to prepare medicines. But we know that every year we have, but we don't have like an actor that can get all the data. So this is where can maybe predictive can play the most value. We don't have enough professionals. Actually, I'm a medical doctor, and I worked in rural areas. I am a general practitioner, and I had to be a cardiologist, a pneumologist, and all of that. So if we were going to implement, it can play a huge importance on the diagnostics. The other initiative that can have a good impact, it's strengthening our health information system to make us, or to possibility us to make better decisions. So those are the many initiatives. Thank you.
Obrigado, Francisco. Finally, let me turn to our colleague from Democratic Republic of Timor-Leste, Narciso. Boa tarde. Many countries are still preparing the foundations needed to responsible AI adoption. From your perspective, what conditions need to be in place when strengthening digital health infrastructure and preparing for the responsible scaling of AI-enabled health services?
Thank you. Thank you for the question, distinguished colleagues. For a developing nation like Timor-Leste, advancing toward AI-enabled health service require building the fundamental digital bedrock first. We cannot discuss advanced AI development without solid foundation health data. For us, the absolute priority is establishing robust interoperability electronic health record system and expanding digital connectivity across our municipality health facility. The primary foundation is data readiness and structural equity. We must ensure that digital health infrastructure reaches our most vulnerable and remote population. AI tools reflect the entire nation, but prevention algorithms bias. Furthermore, we must integrate this technology into basic public health workforce. In Timor-Leste, we recently achieved the historical elimination of malaria and lymphatic filariasis by relying heavily on localized surveillance and targeted public health data. The Foundation for Responsibility AI Scaling is an established digitalized public health system where digital infrastructure serves as equalizer and not a divider. Thanks. That's all my response to your question.
Thank you very much, Narciso. Thank you for all our panelists. Eva, I would be interested to hear your reflections on what you have just heard. Does this mirror your experience and findings in research? Although your countries represent different regions, different health system models and different levels of digital maturity, several common themes have already emerged. This reflection provides an excellent transition to our second round. Please.
Yeah, thank you so much for the invitation to join this panel. So maybe to my background, so I'm a medical doctor, but I work in a research institute on applied science and on standardization of AI. And it really resonated what all of the panelists were reporting from their experiences with implementation of AI in health. I think it is very interesting to see that although we are from different countries, we all have similar challenges to face. And maybe from a research perspective, so what I find important to also mention is that the point of data availability, I think it's important that we really make sure to also produce and also provide access to high quality data sets, and also too, that was mentioned already in the other panels and presentations, etc., to really create the foundations for responsible AI use. And what I think is important to consider here is that we also need to align on a similar terminology and language when we talk about all of these challenges. For example, in my research institute, I'm a medical doctor, but most of my colleagues are from different backgrounds. They are mostly mathematicians or computer scientists. So they sometimes don't really understand what it means to actually be in a clinical setting, how messy the clinical data sometimes is. So I think what is really important when we think about implementation is to address all of these challenges and also to bring together the different teams from different disciplines. And as I heard from the other panelists, for example, to really see that we do this AI implementation on an evidence-based level. So, for example, I can also bring an example from my own work. So we are also taking part in the WHO ITU WIPO Global Initiative AI for Health that looks into to standardization and to bringing together different international experts to develop guidelines and best practices, but also to see how we can then implement it in clinical settings. And what we, for example, discovered when we wanted to translate a framework on clinical evaluation in a resource-constrained setting in Kenya, we tried to, we did this exercise to really understand like what are the contextual challenges, what is needed. So what I think is important is to really do this kind of studies and also to foster this kind of oversight from governments and collaboration with research institutes, but also with other different stakeholders.
Thank you, Eva. Several important messages have emerged from this discussion, no doubt about it. Even when AI has been implemented and successfully scaled, one fundamental question remains. How does we know it continues to work? I therefore like to conclude our discussion by asking each of our panelists to reflect on how countries should evaluate success over time. Mr. Ndoko, how does Indonesia measure whether AI is improving health outcomes, service efficiency, and equity? And how do you determine when an AI solution has demonstrated sufficient value to justify broader national scale-up?
Thank you. To safely manage and validate AI scaling decision is without suppressing innovation. Indonesia has established a formal regulatory sandbox for health technology innovation. We assess innovation through 6 distinct clusters, including medical diagnostic, wellness wearable, and telehealth. Before any AI solution is permitted for widespread national rollout, it must enter this regulatory sandbox to verify its safety, efficacy, and strict regulatory compliance. Besides that, we closely monitor service efficiency and workforce burden. For example, during our recent proof of concept or POC for AI-powered data scraping to bridge regional primary care system with national health platform, we evaluate how effectively AI could automate data field to eliminate the pain point of double entry for our healthcare workers. Thus, automation and data readiness metrics directly guide our data simplification and synchronization strategy before any country-wide expansion. Ultimately, solutions that successfully clear our sandbox criteria and demonstrate a measurable capacity to solve major public health challenges are integrated into national incubation program for nationwide deployment. That's.
Thank you very much. Deputy Director Aydar, deployment is only the beginning. Once AI tools are in routine use, what should government continue monitoring to ensure that these systems remain safe, reliable, effective, and worthy of public trust?
Thank you for the question. From Kazakhstan's perspective, safe scaling of AI in healthcare requires 4 essential foundations. The first building block is trusted clinical data. AI cannot be safely scaled if data is fragmented or not interoperable. This is why Kazakhstan now is developing smart data healthcare system as a unified clinical data environment. It is designed to consolidate data from all health information systems, improve data quality, and create a more reliable basis for analysis, validation, and future AI development. The second building block is clear regulation. We need to distinguish between non-clinical AI, administrative AI, and clinical AI. If AI affects diagnosis, treatment, or clinical recommendation, it must follow a stronger regulatory pathway, including medical devices
And the third building block is expert assessment before scale up. And fourth building is integration into clinical workflows. Thank you.
Thank you very much, Deputy Director Adar. Dr. Ismanbayev, building trust amongst clinicians is often one of the greatest determinants of successful AI adoption. What has been the most important in developing confidence among healthcare professionals, from training and leadership to involving clinicians throughout implementation? And how do we ensure AI solutions meet the quality and safety expectations of both professionals and patients?
Thank you. Thank you for the question. Let me start with one lesson from our experience in Kyrgyz Republic, because experience is often more valuable than theory. We implemented a pilot AI system for interpreting medical images in a vascular system, and the AI's conclusion did not match the clinical assessment of our doctors. Further analysis showed that the model had not been properly validated for our population. So that's why the pilot was stopped. That's why the pilot, this model was learned in the population who lives on the 300, 200 above the waterline. But in Kyrgyz Republic, it starts from the 1,000 to the 4,000. That's why in our population, the vascular system is a little bit different. And what protected patients was not technology itself, but the clinicians that trusted their own professional judgment and questioned that AI's recommendation instead of accepting them automatically. That critical thinking became our most important quality control mechanism. This is why we believe trust cannot be created by asking clinicians simply to trust AI. Trust develops when healthcare professionals know that they remain the final decision makers and that AI is to support, not replace the clinical judgment. And as for quality and safety, we believe AI should be regulated in much the same way as medical devices. Before deployment, it must be validated, tested on the relevant population, and monitored in real clinical practice. And this is exactly the approach Kyrgyzstan. This is incorporating it into its emerging AI regulatory framework through phased implementation, mandatory piloting, validation, and incentive reporting. It's the same like clinical trials with another one, devices, drugs, and so on. Yeah, thank you.
Thank you very much. Francisco, how does Mozambique define a successful AI implementation? Which indicators or outcomes do you believe are most meaningful when assessing whether AI is generally strengthening the health system?
Thank you. Actually, I can't answer this question based on my experience because we have some pilots. We didn't scale it. I think on none of the implementation that we have now. But we think that the most values are the outcomes. If it improve the outcome for the patients? And as I said earlier, we are measuring it by if it is how many children we vaccinated using AI, how many patients, those are examples. If we are shortening the time of waiting to see a specialist those are the other meaningful outcomes that you measure. And if you can sustain this implementation. And this, I think this is the question that always make when I'm discussing if I'm gonna implement AI. Because if it's not giving the outcomes for the patients, it's difficult. If you can't sustain this, although that means I can't use this in my country. So those are the main outcomes, the main KPIs that we use. Mostly the outcomes for the patients, because the regulations obviously is important, but if not, if this doesn't give directly outcomes for the patients, it's not important. Thank you.
Obrigado, Francisco. Narciso, what should be required from technology partners and vendors to ensure AI solutions remain sustainable, locally relevant, and capable of evolving beyond isolated pilot projects?
Thank you. The Minister of Health must transition from the passive consumers of technology to the active regulators. To hold vendor accountable, we must implement strict, localized and regulatory framework and open standard mandates. Vendor must not treat developing nation as a test bed for the unverified algorithms. In Timor-Leste, we look at the accountability through a dual lens of medical and legal standards. First, we must mandate that any AI solution is interoperable with our existing national data system using open standard. Prevention vendor lock-in. Second, contract agreement must include in mandatory long-term technical support and local capacity training clauses. Finally, vendor must provide a local reference if any AI diagnostic tool cannot function smoothly within the practical constraints of a municipal clinic in a developing country, or if it is required constant high bandwidth internet that isn't used universally available and it is not sustainable. We hold them accountable by trying procurement to real-world localize the performance matrix. Thank you.
Obrigado, Narciso. Before we move to questions from the audience, if you have time for that, I don't think so, but we'll see. I would like to ask each panelist one final question. I invite you to answer in no more than 30 seconds, in one sentence. What is the single most important condition for building a trusted national AI ecosystem that can safely scale and deliver lasting value for people? Let's begin with Indonesia and then continue across the panel to Lian, okay? Go ahead, Aris.
Okay. Of course, to implement AI, I think we can do ourselves. We have to collaborate with the other, with stakeholder. That means the most vital condition is regulatory agility combined with active ecosystem co-creation. Indonesia has established a dedicated committee on the utilization of AI in health, bridging together AI engineer and medical professional. So we are building public trust through initiative like the Indonesia Healthcare AI Hackathon to ensuring our national AI development address strictly to the WHO and ASEAN ethical principle of AI governance, fostering transparency, safety, and human well-being.
Thank you very much, Aris.
For us, the most important condition is evidence-based trust. This means that AI must be built on reliable clinical data, introduced through clear regulation, validated in real healthcare settings, and used under physician oversight. Only when patients, doctors, and regulators trust the data, the process, and the results, AI can be scaled safely and deliver lasting value. Thank you.
Thank you. Please. Dr. Mazmambayev, please.
I forgot the question.
The question is, in one sentence, what is the single most important condition for building a trusted national AI ecosystem that can safely scale and deliver lasting value for people? 30 seconds, please.
I think there are like my previous question or answer, I think.
Okay, thank you very much.
This thing.
Francisco.
Okay, I'll say one. There are more, but I'll say one. And it's not related to technology, but to people. This is not only applicable for AI and digital health. It can be applicable for other interventions. And for us, like in Africa, this is important, and you understand it's sustained political leadership. Because without this, you can't implement and scale nothing. So this is the one. If you have this, for example, in my country, you can implement and scale ever AI you want. So this is one. Thank you.
Obrigado, Francisco. Narciso, por favor.
Thank you. The single most important condition is the trust through a capacity. We can have the most advanced regulation and the infrastructure, but if our primary healthcare workers, clinicians, and citizens do not trust or understand the technology and the ecosystem will fail. We build the trust by investing heavily in the digital literacy of our health workforce, ensuring that AI is explicitly viewed as an empowering tool to support human clinical judgment rather than a black box trying to replace it. Thank you.
Obrigado. I'd like to bring Eva again. Eva, what are the key takeaways that you can take from this panel discussion today?
Yeah, thank you very much. So it was very insightful to listen to the different reportings from the different countries and to see like where there are overlaps. And I would say that something that stuck with me was the mention of trust. I mean, it was also already throughout the conference very important to think about this and the role of trust, how we can really address it. And I think it is important also if we think about the scaling of AI that we need to trust the AI tools, but not blindly trust them, but of course, think about this when we implement AI systems. And then I think it is important, or like what I heard like from the panel too, is to support an enabling environment, like that institutions and also the infrastructure, that the workforce, the capacities are there to support AI implementation in a responsible way. And I think what is also important to think about, like the short, medium, and long-term benefits of AI, also considering what kind of economic but also human factors are involved there. So I'm very happy to be in this panel today and to reflect on this insight. So thank you.
Thank you very much, Eva. The discussion was so rich that you don't have time for questions from the audience. So we'd like to thank our panelists. And I'd like to thank also Professor Janja. I needed one like this. For providing such an inspiring and thoughtful, provoking introduction that helped frame today's discussion. Please join me in thanking our expert speaker and all our panelists for their valuable contribution. Thank you very much.
Thank you very much, Luís Góes Pinheiro. We will now close this first day of the Global WHO AI Conference on Shaping AI in Health with reflections by Alain Labrique, WHO HQ, and Álvaro Almeida, Executive Director of the Portuguese National Health Service Executive Directorate. Please welcome to the stage once more Alain Labrique.
It's the last time I'm inviting Herco to a meeting. He's my personal cheering squad. Well, what a day. What a day. Fantastic to have this many folks still here with us. So, Excellencies and ministers and colleagues, first of all, thank you to Portugal and to WHO Euro, the panelists, and to all of you who stayed the distance. So this is when we give out prizes that you all waited till the end for. So you're deserving of that. But I think I want to start by quoting the most eloquent comment that I heard today from Mozambique. Dr. Edson, I hope we all leave this meeting as different people from when we arrived in Lisbon. That was such an eloquent thing to say, and I think that's the marker of a successful convergence. For any meeting, that should be the indicator of success. So, muito obrigado. I think you deserve a round of applause for that. So this morning, health was described as having a duty of care that other sectors cannot claim. And I think from 8 hours later, the duty has been described from 6 regions and very much confirmed. So I'd like to reflect back 3 things that today proved. The first is that government belongs in the driver's seat. The regulation panel a few panels ago said it very plainly. We heard about Korea's comprehensive framework. We heard about Guinea-Bissau choosing to govern from the start. And we heard about Thailand building AI literacy alongside health literacy. And the technology in today's conversation turns out to be the easy part. As one slide from Marco Marcella put it, adoption is a system, architecture, oversight, governance, human capacity. And Portugal then reminded us that building the foundations of responsible AI begins before adoption of AI. The second reflection is that context comes before the technology. Every example today, Angola, India, Iran, Portugal, began with a gap in the health system and looked for the tools that might close that gap. And the tools themselves vary enormously with risk. I always like to think about AI as a zoo, filled with many animals of different shapes and sizes. A giraffe is not a hyena, a rabbit is not a lion. Each comes with different risk, which one we can pet, which one we can feed, and which one we should keep carefully behind protective bars or a moat. And 3 things in AI tell us which animal we face: the level of autonomy, the proximity to the patient, and how much the clinical decision rests on the AI's output. So our job is to classify each animal honestly and to regulate each accordingly. So the harmless move quickly and the dangerous are held to account. But as we heard from Professor Genja, got it right, didn't I? First time, thank you. Tashakuri dirim. We need clear tests, questions, and guidelines that are implementable and practical. The AI zoo is difficult. We can often find a platypus, which when the first naturalist came back to the UK with a platypus specimen, he was thrown out of the academy because they thought he had surely fictitiously created this animal with a duck's beak and who laid eggs. But we can also find a wolf in a sheep's coat, which is benign to look at, but potentially dangerous. And so we need to extend that analogy to how we think about these AI tools. The third is that sovereignty means responsibility. Interoperability and digital public infrastructure came up unprompted in nearly every session today. Turkmenistan said it most simply yesterday: you cannot build a house without strong foundations. And the countries best placed today are those that invested in infrastructure, like we heard from India, over the last 15 to 20 years. But this doesn't mean that countries starting today have to launch from zero. We're here precisely for that reason, to learn how to leapfrog and to understand what we must have to start? What are the non-negotiable preconditions for the adoption of AI? And to identify the other things that we can build as we go forward. But there's also unfinished business. Earlier this morning, I mentioned that the evidence is younger than the enthusiasm. We heard about some really exciting pilots today from Indonesia and from a number of other countries. And good pilots still have to prove themselves at scale. We owe patients that harder evidence, because just because something is AI doesn't allow it to circumvent the standards of quality we set in the health system. Brazil framed the stakes very well. Adoption will happen, and the task is to see that adoption arrive with evaluation and accountability attached. When accountability is diffuse, both speed and scale will suffer. The one thing that's still open from this morning is the governance gap. And health still needs a seat at the diplomatic and political tables where this technology is being decided. But we don't need to regulate from scratch just because we're talking about health. There's a lot of cross-sectoral rules being put into place. And the question I think we have been asking ourselves over the course of today is whether there are additional protections and safeguards from what is being established for all sectors that health needs. What is it that we need specifically? Is it accountability? Is it traceability? Is it transparency of where decisions are being made in a multi-agentic system? Those are the questions I think we need to ask to add on top of the regulatory layers that are being established. Performance drift, model withdrawal, workforce transition, several countries have already shared their lived experiences with these. And one thing that struck me really from this last panel was around when general purpose tools that are not built for purpose, for health, are used for tasks that they were not intended for, we see those tools risking going very, very wrong. Tools are often sycophantic. The models tell us what we want to hear. They reinforce our biases. And the thing that I'm starting to also recognize is that they also don't know the limits of their own competence unless we train that into those models. And so Kiran Vaska from India pointed us further ahead. He said that as autonomy becomes real, humans will not always remain fully in control. And that's a difficult question we have to grasp with. There are many unknowns here, and unknown unknowns beyond those unknowns. And I'll quote Confucius here because there's a saying that real knowledge is knowing the extent of one's own ignorance. The machines fail that test, but we as humans cannot afford to fail that test. So I'll leave you with one ask. Let's take what was said in this room today back to our capitals as the basis to inform multilateral vehicles like the Global Strategy on Digital Health to help WHO and implementing partners in the room ensure that the guidance we're building is what you need to make good decisions. No one here needs to solve this alone. As Brazil said, AI is a strategic global priority, and multilateral platforms are how we lead together. And that's why most of us are here gathered in Lisbon. Let's also keep the deployment of AI in lower resource settings at the center of our work, because that's going to differentiate whether AI becomes a tool for inequity or a tool for justice. To paraphrase again what Kiran from India says, it's also tempting to focus on AI as it is today. But the governance challenge is to imagine the animals that we haven't yet discovered. We need to regulate for where AI is going, not just where it is today. This morning I said health measures its consequences in mortality and morbidity. Everything we heard today from our countries, from our experts, confirms that we are taking this very seriously. What this looks like on the ground in a single health system is what my colleague Alvaro Almeida is now about to share with you. Over to you, Alvaro.
you very much, Alan, for sharing your impressions for today. I am now pleased to hand over the microphone to Álvaro Almeida.
Good afternoon, Excellencies, ladies and gentlemen. As we conclude the first day of this conference, I would like to express my sincere thanks to everyone who has contributed to its success. I'd like to thank WHO Europe, and particularly Dr. Ernst Kluge, Dr. Lebrick, all the ministers that were invited, and above all, the Government of Portugal in the person of Minister of Health, Ana Paula Martins. It is an honor to close a day this rich in dialogue and reflecting what we all heard and thanking the people who made it possible. It is a privilege to Portugal to host such a high-level conference. It is a pleasure to welcome here in Lisbon so many representatives from WHO member states, WHO regional staff, technical experts, and partners. Today's discussions have shown that the challenges we face are shared, and so too must be the solutions. Throughout today's discussions, several important themes have emerged. Across the different sessions and perspectives shared today, one common message has become clear. Artificial intelligence offers enormous opportunities for health systems, but real progress depends on how responsibly we choose to develop and implement these technologies. From today's discussion, I'm taking a number of key points that I would like to remind you. AI must provide an answer for the problems we have in our health systems, especially the problems of those who are more in need. AI must benefit all. So equity should be one of our main concerns when implementing AI, and for that to happen, government must be in the driver's seat. Data sovereignty is crucial, but should not be confused with isolation. And trust is the foundation of healthcare. So cybersecurity is crucial to make patients and professionals trust AI, and most importantly, we must create systems that catch errors in AI systems. Today's discussion also reminded us that the bottleneck for deployment of AI in healthcare is not AI itself. It's not the technology. The bottleneck is everything else around AI, especially AI is a workforce transformation challenge. We have heard about how several countries are working to ensure that technical innovation safely improves health, how to use AI that serves public health, and AI that is scalable, safe, and human-centered. One final important point that we're taking from today's discussion, technology alone does not improve healthcare. Progress depends on strong governments, good data, robust evidence, and above all, the trust of patients and healthcare professionals. Innovation creates real value only when it strengthens the delivery of care and improves health outcomes. These are also the principles that guide Portugal's approach to AI. Here we are continuing the digital transformation of the National Health Service with a clear objective: to ensure that digital innovation translates into better care for citizens and better support for healthcare professionals. We see AI as a practical tool to improve clinical decision-making, reduce administrative burden, and help healthcare services deliver more timely, efficient, and person-centered care. Ultimately, the value of AI will not be determined by the technology itself, but by the difference it makes to patients, healthcare professionals, and the way our health systems deliver care. International cooperation will be essential to achieving these goals. No country faces these challenges alone, and no country should seek solutions in isolation. By bringing together member states, experts, and partners, the World Health Organization plays a unique role in supporting shared learning, common standards, and practical cooperation. As we look ahead to tomorrow's discussions, three themes stand out as particularly important. First, building the foundations for sustainable AI adoption. Tomorrow's discussion will focus on how countries can strengthen the workforce, institutional capacity, governance arrangements, and partnerships needed to move from ambition to implementation. We will hear directly from patients, clinicians, and member states about what is required to embed AI responsibly within health systems. Second, investing in AI responsibly and at scale. As AI moves beyond pilot projects, countries will need to make informed decisions about investments, financing, and long-term sustainability, ensuring that innovation delivers real value for patients and healthcare professionals. Discussions will examine the economic implications of AI in health, approaches to financing and scaling innovation, and the role of international partners in supporting sustainable adoption. Third, translating readiness into collective action. Tomorrow offers an opportunity to learn from one another, share practical experience, and identify common priorities that will strengthen health systems across all regions. I expect that tomorrow we'll have discussions that will help move the conversation from vision and strategy towards implementation, ensuring that innovation delivers tangible benefits for patients, healthcare professionals, and health systems alike. We had a wonderful discussion day today. We've seen what can be achieved when countries, institutions, and experts come together around a shared purpose. Let us carry that same spirit of collaboration into tomorrow's discussions, and above all, into the work that follows this conference. Thank you once again for your participation, your commitment, and your contribution to this important dialogue. I wish you all a pleasant evening and look forward to continuing our discussions tomorrow. Enjoy Lisbon. Thank you very much for your participation.
Thank you for sharing your reflections on today's discussions. I think we can all agree that the conversations that are taking place here are timely and will continue beyond this conference. Before we close for the day, I would like to mention two more things. First, all the photos taken at this event will be available from the website that you can see on the slide. Second, the conference program tomorrow starts at 9 a.m. sharp. And now, I would like to thank again all the speakers, panelists, and moderators for sharing their perspectives on AI in health today. Finally, I would like to ask all of you to please join us for an evening reception at the Unicorn Factory rooftop at 4:45 p.m. Thank you.